Wonderful. So good afternoon, everyone. I'm going to call this meeting to order on the Assembly Committee on Health and Human Services. Madam Secretary, will you please call the roll?
Assemblywoman Benitez Thompson.
Here.
Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews. Assemblyman Orentlicker.
Here.
Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong.
Here.
Assemblywoman Thomas.
Here.
Assemblywoman Titus. Chair Wynn.
Here. It appears everyone is present today. So welcome. Welcome to our audience joining us here in person. We have a full room, which is always exciting. And also welcome to our audience joining us either online by phone or virtually on our YouTube channel. Today we will start with the work session, and we do have 3 bills. I realize I have crammed a lot into this agenda here today, so thank you everyone in advance for your patience. Before we begin, just some housekeeping matters. I'd like to make several of those. For individuals that are present in the meeting room, please keep your face coverings on and maintain social distancing. And members of the public, again, you may provide testimony in various ways, which are all listed on the agenda. If you are not able to, or you would like to add additional information, you can always do that in written form and submit that up to 48 hours after the meeting adjournment. Finally, if you have electronic devices, especially cell phones and laptops, in fact, I'm looking at mine because I know mine is on, please mute those. I know we all love those binging and dinging that comes from our computers and our phones, but if we could turn those off, that would be great. And with that, we will move to our first agenda item, which is the work session document. And just for the people that are on the Zoom or in the room, Senate Bill 188 at this time, I will be taking that off the work session document, and we will go forward. And I will start from the top with Senate Bill 21. Mr. Ashton, if you could go over summarize the bill.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst, and just my usual thing I want to say as a nonpartisan member of the LCP, I can neither advocate nor oppose any measures that come before you today. So, members of the committee, we said before we will have a consent calendar today, but we actually will just move through every single bill on the work session in the work session document and do not the consent calendar. Therefore, we will start with Senate Bill 21, which we heard on April 28th. And this bill provides that in addition to the current requirements to conduct background checks on current employees, public or private institutions and agencies to which a juvenile court commits a child, and certain facilities that provide residential mental health treatment to children, must conduct background checks of applicants for employment to determine whether a potential employee has charges pending against him or her, or has been convicted of several specified crimes. The bill makes certain other changes as outlined on the bill page. There were no amendments, Madam Chair.
Thank you. With that, I will take any questions from committee members. Seeing none, I would entertain a motion to do pass at this time. Actually, is it amend and do pass? No, it's just do pass.
So moved.
Do I have a second?
Second.
All those in favor say aye. Aye. Any opposed say nay.
Nay.
And if I can get hands so I can make this for the record, it looks like we have Assemblywoman Black, Assemblywoman Titus, Assemblyman Hafen, Assemblywoman Krasner, I got you, Assemblywoman Krasner, and Assemblyman Matthews. With that, there is a majority, and so the motion does pass. And I will assign that floor statement to Assemblywoman Summers Armstrong. And if we can go next to the next on our work session document, Senate Bill 146. Mr. Ashton?
Thank you, Madam Chair. For the record, Patrick Ashton, LCB. Senate Bill 146, we heard this bill on April 28th. This bill revises laws related to behavioral health care for children with emotional disturbance who are subject to the jurisdiction of a juvenile court for reasons relating to protection from abuse and neglect. Specifically, when such a child is admitted to a public or private inpatient psychiatric treatment facility, The bill requires the administrative officer or staff of the facility to ask the person or entity with legal custody of the child whether he or she has a healthcare provider who regularly provides mental or behavioral health care. If the child has such a provider, staff of the facility must make a reasonable effort to consult with the provider concerning the child's admittance and care and to coordinate on a plan to discharge the child from the facility. There were no amendments, Madam Chair.
Members of the committee, do we have any questions regarding Senate Bill 146? Seeing none, at this time, I would entertain a motion to do pass.
Do pass.
I have a motion from Assemblywoman Peters and a second from Assemblywoman Titus. Do we have any questions on the motion? Seeing none, all those in favor say aye. Aye. All those opposed say nay. That was a unanimous and the motion passes, and I will assign that floor statement to Assemblywoman Titus. Next, if we can move to Senate Bill 156. Mr. Ashton?
For the record, Patrick Ashton, Committee Policy Analyst. Senate Bill 156, we heard this bill on April 23rd, and the bill expands the authority of the Division of Public and Behavioral Health of the Department of Health and Human Services to issue an endorsement as a crisis stabilization center, not just to a psychiatric hospital, but to any licensed hospital that meets certain requirements. Additionally, the bill expands the existing requirement that DHHS take any action necessary to ensure crisis stabilization services provided at a psychiatric hospital with a crisis stabilization center endorsement are reimbursable under Medicaid to include such services provided at any hospital with this endorsement. Finally, SB 156 makes certain conforming changes to existing law. There were no amendments, Madam Chair.
Thank you. At this time, are there any questions from committee members? Seeing none, I would take a motion to do pass.
So moved.
A motion by Assemblywoman Peters. Do I have a second?
Second.
I have a second from Assemblywoman Gorlow. Do we have any comments on the motion? Yes. Assemblywoman Titus, go ahead.
Thank you, Madam Chair. I'm going to vote this out of committee with the right to reserve, change my vote. Thank you.
Thank you. And I'll remind all committee members, you always have the right to change your vote. And I know all members have been very diligent about letting me know if they do plan on doing that. So I appreciate that. Do we have any other comments on the motion? Seeing none, all those in favor say aye. Aye. All those opposed say nay. And if you could raise your hands, I think I saw Assemblywoman Black and Assemblyman Matthews as nays. The motion carries. Next, if we can move to Senate Bill, oh, I'm sorry, floor statement. I will give that to Assemblyman Orenlicker. If we can go next to Senate Bill 251. Mr. Ashton? I'm sorry, I caught Mr. Ashton off guard. I called an audible.
Not off guard, Madam Chair. I got it. For the record, Patrick Ashton, Committee Policy Analyst. We heard Senate Bill 251 on April 23rd, and this bill requires primary care providers to attempt to determine whether adult women to whom they provide services have a personal or family history of certain cancers or meet other criteria for which the United States Preventive Services Task Force recommends screening for a harmful mutation of the BRCA gene. If certain criteria are met, primary care providers must screen for the mutation, provide written notice of the need to discuss genetic counseling and testing, provide genetic counseling, and, if clinically indicated, provide genetic testing. Finally, certain public and private health plans must cover screening, genetic counseling, and testing for harmful BRCA gene mutations where such services are required as set forth in the bill. There were no amendments, Madam Chair.
Thank you, Mr. Ashton. Members of the committee, are there any questions regarding Senate Bill 251? Seeing none, at this time I would entertain a motion to do pass. I see a motion from Assemblywoman Gorlow. I think that's who it was. Is that it? Yep, and a second from Assemblywoman Titus. Do we have any comments on the motion? I think we do. Go ahead, Assemblyman Ornlicker.
Thank you, Chair. David Orentlicker, Assembly District 20 for the record. While I applaud the intent and much of this bill, there is one provision that I think is problematic. The one granting protection from professional discipline for physicians. I think that's a bad precedent to create, to excuse physicians from their professional responsibilities to patients. So I'll be voting no.
Any other comments regarding Senate Bill 251? Seeing none, all those in favor say aye. Aye. All those opposed say nay.
Nay.
And I have a nay from Assemblyman Ornlicker, and the motion carries, and I will assign that floor statement to Assemblywoman Black. Next, if we can move to Senate Bill 309. Mr. Ashton?
Thank you, Madam Chair. Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Senate Bill 309, we heard this bill on April 26. It establishes a reinvestment advisory committee in each county of the state with a population of 700,000 or more, which is currently Clark County. The bill outlines membership of the committee and prescribes the duties of a reinvestment advisory committee. There were no amendments. Madam Chair?
Thank you, Mr. Ashton. Members of the committee, are there any questions regarding Senate Bill 309? Looking around, seeing none, I would entertain a motion to do pass at this time. So moved. I have a motion from Assemblywoman Peters and a second from Assemblywoman Summers Armstrong. Do we have any comments on the motion? Around. Seeing none, all those in favor say aye. Aye. All those opposed say nay. Nay. And if you could raise your hands. So I have Assemblywoman Black, Assemblyman Matthews, Assemblywoman Krasner, Assemblyman Hafen, and Assemblywoman Titus. The motion does carry. And I will assign that floor statement to Assemblywoman Gorlow. Next on our work session, I will move to Senate Bill 364. And Mr. Ashton?
Thank you, Madam Chair. For the record, Patrick Ashton, Legislative Council Bureau. Senate Bill 364, we heard this bill on April 21st. It requires the State Board of Health to adopt regulations requiring a hospital or independent center for emergency medical care to provide certain training to employees who provide care to victims of sexual assault or attempted sexual assault. These facilities must inform victims of their right to receive emergency contraception and provide such contraception upon request. Failure to comply with the bill's requirements may result in disciplinary action for these facilities, including administrative sanctions or the denial, suspension, or revocation of a license. There were no amendments.
Thank you, Mr. Ashton. Members of the committee, are there any questions regarding Senate Bill 364? Looking around, seeing none. At this time, I would entertain a motion to do pass. I have a motion from Assemblywoman Peters. Do I have a second? I have a second from Assemblywoman Titus. Do we have any comments on the motion? Go ahead, Assemblyman Matthews.
Thank you, Chair. I'll be voting yes today, but we'll be reserving my rights for the floor. Thanks.
Thank you, Assemblyman Matthews. Do we have any other members or any comments from members? Seeing none at this time, all those in favor say aye. Aye. All those opposed say nay. I have one nay, it's Assemblywoman Black, but the motion carries, and I will assign that floor statement to, my list, excuse me. I will assign this to Assemblywoman Krasner. Next on the work session document, we have Senate Bill 376. Mr. Ashton?
Thank you, Madam Chair. For the record, Patrick Ashton, LCB. Senate Bill 376, we heard this bill on April 28th. It requires child welfare agencies to assign one of the following dispositions to a report concerning the possible abuse or neglect of a child upon determining that an investigation is not warranted or upon the conclusion of an investigation. Substantiated, unsubstantiated, unable to locate or contact, or administrative closure. In addition, SB 376 prohibits the reporting of dispositions other than substantiated to the statewide central registry for the collection of information concerning the abuse or neglect of a child, and prohibits the release of information from the central registry regarding reports of child abuse or neglect that received a disposition other than substantiated except to child welfare agencies. There were no amendments, Madam Chair.
Thank you. Do we have any questions from committee members regarding Senate Bill 376? I'm looking around, seeing none. At this time, I would take a motion to do
Motion
pass.
to do pass?
Thank you, Assemblywoman Krasner. With that motion, do I have a second? I have a second from Assemblywoman Peters. Do we have any comments on the bill at this time? Seeing none. I'm looking around, seeing none? Okay. At this time, I will, all those in favor, say aye. Aye. All those opposed, say nay. That passed unanimously, so that motion carries, and I will assign that floor statement to Assemblywoman Thomas. Next and last on our work session document, we have Senate Bill 398. Mr. Ashton.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Senate Bill 398 we heard on April 21st. It requires the Juvenile Justice Oversight Commission to submit a report to the Legislative Committee on Child Welfare and Juvenile Justice by August 1st, 2022, containing an update on the progress made by the Division of Child and Family Services of the Department of Health and Human Services in implementing its current 5-year plan, as well as any recommendations for legislation relating to improvements to the upcoming 5-year plan, any disparities in the juvenile justice system related to race or ethnicity, and compliance with the Federal Juvenile Justice and Delinquency Prevention Act. There were no amendments, Madam Chair.
Thank you, Mr. Ashton. Members of the committee, are there any questions regarding Senate Bill 398? I'm looking around, seeing none. I did entertain a motion to do pass Senate Bill 398. I have a motion from Assemblywoman Peters. Do I have a second? I have a second from Assemblywoman Krasner. Do we have any comments on the motion? I'm looking around, seeing none. All those in favor say aye. Aye. All those opposed say nay. Can we get a hand? I think I got Assemblyman Matthews and Assemblywoman Black as nays. The motion carries, and I will assign that floor statement to Assemblywoman Krasner. And that concludes our work session. Yay! Good job, you guys. We do have 3 bill hearings. I am going to take them slightly out of order as they are listed on the agenda. I am going to start with Senate Bill 379. So at this time I will, well, let me make sure I have 379. Yes, I see Senator Hardy there. So at this time I will now open the bill hearing on a Senate Bill 379. Welcome to the Assembly Committee on Health and Human Services. Senator Hardy, please begin when you are ready.
Thank you, Madam Chair. SB 379, Joe Hardy for the record, Senate District 12, is interested in data, and we need data in order to figure out how we sit presently and how we want to get more practitioners and providers. So the bill is pretty simple in its organization. So we want to attract more providers, especially for the underrepresented groups and specialties. The mechanics is after you have initially been licensed or certified and you go for renewal, there will be a survey sent, hopefully electronically, in which the practitioner provider will fill out the survey. And the survey is interested in things that will tell us where you're at, and that's on page 3 if you'd like to read the type of license from line 3 down to about 32. And all of those things are the things that we're interested in order to figure out how we can improve our delivery of health and be able to make our people healthier. And then the working group that will be set up with, under the direction of the Director of Human and Health Services, will meet and recognize that they have to make a questionnaire. They'll do that. And then the goal is on page 4, lines 18 through 23, attract more persons, including without limitations, members of unrepresented groups, etc. And then 2, improve health outcomes and public health in this state. The survey response cannot be used to disqualify someone from approval of their license. It is confidential. If this survey will include doctors of every kind, nurses, mental health providers, chiropractors, oriental medicine, podiatrists, marriage and family, counselors, sociologists, psychologists, alcohol and drug, gambling. And in as much as you are interested in alacrity, I am happy to field any questions as long as they're not very hard.
Thank you, Senator Hardy. I am looking around to see if we have any questions. I think we do down there. I see Assemblywoman Titus. Go ahead when you're ready.
Thank you, Madam Chair, for the question, and thank you, Senator Hardy, for presenting the bill. I just had some concerns and questions regarding some of the questions on this questionnaire, and what the purpose is ultimately, because I'm not convinced that to, one of which it's the race and ethnicity on number B, future plans on what somebody's planning on doing. And I'm just wondering, how's that relevant to somebody's qualifications to when they do their license?
Thank you for the question, Madam Chair, if I may.
Yes, and feel free to go directly to the assembly person asking the question, Senator Hardy.
Thank you, Assemblywoman Titus. This survey has nothing to do with the licensing of the person as much as who they are and what they're doing, and the confidentiality is really crucial with this, because if there is a physician or a practitioner that's going to be planning on going somewhere else, we do not want that person to be identifiable, and so the confidentiality will be of utmost importance. It's designed to be upon renewal, so there won't be an issue of, well, I think you kept me out because of, which we're not supposed to be able to do. Now, I did bring Dr. John Packham, who's on Zoom, who can probably answer the mechanics of the questionnaire. I will note that where I'm coming from as, pardon the expression, an old white male, I may not be as trustworthy and trusted in some communities as others. And if I don't have people who look like other people, then they may not trust those people. So I am very interested in getting and recruiting people that are in, for lack of a better word, a BIPOC community, for instance, and having that opportunity to grow the trust factor in the medical and counseling world of Nevada. If that doesn't answer your question, John Packham can probably do a better job.
No, I appreciate that answer, and that's one of my concerns is that it may be used to perhaps not hire somebody or focus on somebody, how they identify, and what if they don't want to answer this? Will it be denial for their licensure?
No, it is not mandatory.
It's going to be an elective
Correct.
option. You can opt in.
Yep, will have nothing to do with your license being allowed to continue or to get, and it is not before you get licensed, it is upon renewal, so it will not affect your hiring or firing. It will be confidential.
That's reassuring. Thank you. And one other question, if I might, Madam Chair.
Go ahead.
So if it's optional, which is a good thing, and then we're going to use it from a statewide level, maybe to identify some priorities and certain recruitments, and I guess that Dr. Peckham has to answer that, what this is going to, how this will help us change how we see it, because in my mind, to solve some of these problems is making sure we encourage people from every background to go into the fields where we need them. And healthcare, as you pointed out, is critical that you have confidence in your provider, that it helps if your provider understands your background or can identify with you and you can identify with them. So I understand that component. But I'm not sure this questionnaire gets us there as more than, it's on the back end already. So that's where I guess I need some reassurance that it's going to help us get that right mix.
And this is where John Packham feels like he wants to say something.
Mr. Packham, go ahead. Please remember to say your name before you begin.
Will do. John Packham for the record. I'm Associate Dean at the UNR School of Medicine. And this bill is that it provides a wonderful, very efficient mechanism for collecting data, not only on physicians and nurses, but any health profession who is renewing their license in the state of Nevada. And I think our primary purpose or idea with the bill is to improve the data that is used to establish and maintain HPSA designation. These are very important for a number of programs that are critical to bringing and keeping physicians and other health professionals in the state of Nevada. And in addition to that, I believe that the bill will improve the collection of data to inform a wide range of where our healthcare needs are by profession. So I think that's all I would add.
Madam Chair, if I may.
Go ahead.
Joe Hardy for the record. I have a little sign sometimes on these places that it says define acronyms, and so Dr. Packham would love to define HPSA for all of us so we're on the same page. Thank you, Dr. Packham, if you can make sure the acronym that you just used is well understood and why.
Absolutely. Forgive me on that. Again, John Packham for the record. HPSA stands for Health Professional Shortage Area. There's essentially 3 types of shortage areas or designations. They are primary care, oral health or dental, and mental and behavioral health professional shortage areas. And these are critical for basically making Nevada providers and facilities eligible for loan repayment, enhanced reimbursement, and so forth. And I would just stress the urgency when we talk about access to care. Access to care is affected by those designations, and it's critical for us to get it right and to take advantage of those particular designations. I'd like to just re-emphasize this is not simply or purely a data collection bill. It's a data collection bill that will inform and improve access in our state.
Thank you, sir, and thank you, Madam Chair, for the questions.
Thank you. Next I will go to Assemblywoman Summers Armstrong.
Thank you, Madam Chair, and thank you, Senator Hardy. I've never met you before, but this is a wonderful introduction on an issue that is very important in my community. Thank you, Dr. Packham, for defining HPSA. I'd like to ask why your request does not include a exit survey, if that's at all possible. Why doctors leave? And I think that I'm curious, and I say that if I just may, Madam Chair. Our family lost our pediatrician. He was our pediatrician from the time my 2 older sons were like 7 or 8 years old, all the way up to our youngest son who just turned 19. He's a black man. We actually grew up in the same city in Oakland, California. We didn't go to the same school, but we had these things in common. And to have a man who looked like my sons take care of them all their life, to be able to speak to them, to be able to have a relationship with them and our families, it made a huge difference in how they responded to healthcare and the instructions that he gave them as they were going through each year. And all of a sudden he was gone. And I never found out why. And I just lost my OBGYN, who was, I've had for 20 years. Same thing, right? So even as we're collecting data about why people re-up their licenses, if there would be any way you all can find out why people leave, because that also might inform why we have shortages here. Thank you.
Thank you. And looks like another question was already asked. Do we have any other questions? Assemblywoman Benitez Thompson, go ahead.
Thank you so much. And so I have questions on I'll start with the kind of the mechanics of how we're going to collect this. So it's section 5, sub 2. So the director shall develop and make available, and the director being 439. So Department of Health and Human Service director shall make available to each professional licensing board. So to all of those licensing boards, A through B, a way to collect this data electronically. So could you, for the record, I guess, tell us how that's going to look, how that will be implemented?
Joe Hardy, for the record, I turn that over to John Packham, who has spent his life doing just that, and I suspect he's going to help all of us understand that. Thank you, Madam Chair.
Go ahead, Mr. Packham.
I'm happy to answer that. Again, John Packham for the record. There's a variety of ways that can be done technologically. And so not to dodge the question, but I think what the licensing boards would like for us to consider or think about on this is when you renew your license online, as you proceed through that renewal process, there would be a link you would click on that would take you to the Department of Health and Human Services, where you would complete a survey that we would have available out there. When you complete that survey, you would then return back, provide your credit card information, and renew your license with the state of Nevada. The whole idea is to make this as seamless as possible so that, again, every 2 years, for most professions, when you renew your license, you're spending maybe 5 to 8 minutes, again, providing very valuable information that the state and other agencies would use to inform policy. There is a document that I hope is out there as an exhibit. It's a background paper put together by about a dozen of us who've been working on this issue, and it provides kind of some great examples of how other states have done this. The beauty of this proposed piece of legislation is that we do not have to reinvent the wheel. There are a number of state models out there. We've received wonderful advice from both the National Conference of State Legislatures as well as the National Governors Association, and they have some tried and true models out there ready to roll if and when we proceed on this. So again, we don't have to reinvent the wheel. There's a variety of ways we can do this, but I'm confident, again, that this is worth the lift.
Go ahead and follow up.
Thank you so much. And so I guess that the next piece would be, are all of the boards in a place where they would be able to do that? I know that just with conversations of different boards throughout different times, they are in different states of solvency. They're in different states of having data tech. I know that with one board, a few years back when they were still doing, many of them still doing paper application renewals, and the cost to go to an electronic version was going to be north of $30,000. And so I want to say a couple sessions back, we were trying to figure out maybe how to pool some of those tech needs among some of the smaller boards. And so just knowing that this is a really big swath of boards, I'm sure you've asked, but so for the legislative record, are all the boards going to be in a place to kind of dovetail into the system that you're talking about?
Again, John Packham for the record. My honest answer would be no, they will not all be in the same place. By my count, there are 28 boards that license or regulate anywhere from 70 to 75 professions, and they are all over the map in terms of the software they use for licensure renewal. Some still do pencil and paper and so forth. But again, I'm hoping that the way that this bill has been crafted or proposed is one that is mindful of those differences and that allows boards to implement this or phase this in as they see fit and with enough time to take into account those variations. So I don't know if that answered your question, but if you've seen one licensing board, you've seen one licensing board.
Madam Chair. Yeah, I appreciate that, and I appreciate the honesty of that, because it's I'm looking at the end of the bill, and I see we've got different implementation dates for different sections. So I guess for those boards that are, it looks like you've done an assessment of the board. So depending on where the boards are at, you're addressing different implementation dates. So is that why we're seeing different ones? Is that the ones who are already doing renewals and licensing electronically, and they can kind of dovetail into this sooner, and then those who are still on paper who need to figure out the way to get to that electronic base, they've got till July 1, 2022? Well, yeah.
Yes, again, John Packham for the record. I think another thing I would point out is that the time in which health professionals renew their license varies again from board to board. Some are on a rolling basis, some are every other year, I believe. Don't hold me to this. The State Board of Medical Examiners, you renew your license every 2 years following. I can't remember what year it falls on, but it's by June 30th every other year. And so the way to think about this is that the data will not start rolling in immediately. It will be phased in over the next couple of years. But in 2 or 3 years, we will begin to have some solid data, again, on health professions, not just practice characteristics, socio-demographic characteristics. It is the pleasure of HHS. We can address some of the concerns raised in a previous question about retirement plans or likelihood of leaving or exiting the profession or the state. I think all of those are important questions. The data will, I think the point I'd want to make is that the data capture will not be immediately, but will be phased in based on the way each board collects that data and the timeline in which they collect that data.
Thank you so much. And then for the boards that are still need to address the tech issue, I guess, does this require them to figure out how to get themselves to an electronic renewal, or would they stay paper and then just like an insert notification in your renewal letter that says, by the way, go to this link and do this electronic or this survey electronically until such point, if and when they can afford the cost to be, do everything online and with all the tech?
Yeah, again, John Packham for the record. I think the answer to that is a qualified yes, and that is, I think this begs that we need to be flexible in how this is implemented and rolled out. Some states have a super agency overseeing licensing, so you're dealing with one type of software and one common way of renewing your license. We're different. Again, each board is different, and I think we will have to be flexible and patient in how this is implemented, given those that variation.
Thanks. And that was my questions on implementation, but I had some about the specific data being collected, just so we can get clarification for the record. Is that okay, Chair? Or do you want me to, I can go to the back of the line.
You know what? Go ahead.
Okay. So just for the record, on this, in subsection 5, the number F, the working hours and then the location. So I guess what you would want to know, I guess, what are you looking for in that? When someone, a licensee goes to complete that, is that going to be, I guess, are you looking for like a qualitative sentence, or are you looking for a delineation of their hours?
Yeah, again, John Patton for the record. Let me just kind of speak to the general intent of that. I did a survey about 10 years ago on registered nurses in the state, and one of the things that I discovered in that survey is that about 15 or 20% of those nurses worked in a county that was different from where they had their licensure renewal mailed back to them. So while it's good to know how many licensed physicians or nurses work in a given county or part of the state, we really need to know where they're practicing, where they're working, the type of employer they're working for. You're working in a hospital or a clinic setting or a public health agency and so forth. So that the intent of that type of question is to get a better sense, for example, with respect to health professional shortage area designation, are you providing care in a medically underserved area? What percent of your patient panel or population is on Medicaid and so forth? So that as we're trying to assess that, we're getting better information on actually where you practice medical care, as well as are you providing patient care? A number of physicians work in administrative or university settings. This will get us a better handle again on exactly where care is being provided, how much, and the types of populations those professionals are serving.
Thank you for that. So because the list of that 629 is so exhaustive, your intent would be that those professions that are listed who work in the healthcare field would take the survey, but if they weren't working in the healthcare field, then I guess there wouldn't be just the assumption that just because your licensing type is listed in here that you are necessarily working in the healthcare field. That's something that you would kind of ask first and foremost. For some of them, they're more obvious, like physicians, but some of the other ones, they may or may not be in the healthcare field. Like you think of social workers, some might be in child welfare and some might be in medical. So I guess you would ask that question first. Are you in the healthcare field? And then if you are, then you want to capture this data, because otherwise I imagine it's just erroneous data you're collecting from people who aren't in the medical field.
Yeah, again, John Packen for the record. Our idea would be to still ask every health professional renewing their license so that we could get our arms around that. For example, if we're getting data on, for example, physicians whose primary specialty is family medicine, it's important to not only know kind of what the universe of family medicine physicians are in the state or a given county and so forth, but from that, how many are actually providing patient care? How many have an active license? How many are working full-time and so forth? Because we know that for every 100 physicians in family medicine, maybe 80–85% are actually in direct patient care. That subset, some are working full-time, some are working part-time. And again, as we try to get our arms around what the capacity of the state is and where we may or may not have gaps in provider coverage, this type of data will really inform that much better than anything we currently have right now. I can tell you how many family physicians are licensed in Clark County. I have no clue on what the FTE of that number is providing direct patient care or serving Medicaid patients or working in medically underserved areas and so forth. We need answers to those questions.
And I appreciate that. You keep using the example of physicians, but when and this is why I'm asking for the record, because that list, tell me if I'm reading it wrong, because, that happens too. But I see the reference to all of the healing arts. So you're not looking just for a subset of the healing arts. You do mean the entire list of everyone that's in the 629.031. Okay, so since I got a firm yes on that, so then I'm thinking like with some of the licensing types, and I'll just, I'll go to like with social workers, it's anyone who's licensed by the Board of Social Workers, but not all of them work in healthcare. So I guess once you get the data, you'll clean it up so that not everyone who's working in child welfare or working in anything else other than healthcare aren't represented as a part of a workforce, that indeed they're not part of that workforce.
Correct.
Okay.
Again, John Pack, record. I think a real quick way of trying to illustrate that is I'm interested in the state's primary care capacity, and that doesn't mean just family medicine or internal medicine docs. It also means getting our arms around advanced practice nurses and physician assistants who we know are critical to primary care capacity in our state. So pick your profession, you have that kind of variation in how many are practicing, how many are providing patient care versus administrative work and so forth. So I think the answer to that question is yes.
There's just a couple others, like a music therapist in there. They may or may not be in a medical setting. And then what is the other one? I think it's a sports one that may or may not be in, I think it's a sports trainer that may or may not be in a medical setting. So there was just a couple of them that I thought I wasn't quite sure, and we should flesh out on the record kind of what you were trying to scoop up and the scope of it, because it'll be a lot of people through these licensing boards. And some of them ask them, I know my licensing board asked me about the county I work in and the kind of work I do and the institution I work for and all that kind of stuff. So I think for some of the professions, a lot of this won't be new. I'm thinking about how I'm going to answer a lot of these things, which is why I'm like, okay, working hours and location. It's like, well, you might spend part of my time outpatient, might spend part of the time inpatient. So I guess you would just want how many hours I'm in the hospital versus how many hours I'm at the office versus how many hours I'm spending in patient home. So I would just kind of report that. I guess you're going to give me a free form box to report that as more of a qualitative response, right? And as opposed to just a drop down and with numbers, and then you'll sort all of that out.
Yep. Again, for the record, I think the way to think about that, some of the wording or phrasing of the capture of that data are to be determined. And so that the standard methodology in this line of research is to phrase a question in a typical work week. How much of your time is involved with direct patient care, administrative work, teaching, et cetera, and so forth like that. And so, I'm hoping that the bill is not overly prescriptive on the wording of questions and questionnaires and so forth, but leaves some of that down the line, as long as we're, again, going back to an original point I made, finding out how many providers, regardless of what field you're in, are providing direct patient.
Thank you for those questions and those answers as well. I also want to remind committee members, this is a bill that came out unanimously from a work session from the legislative, an interim committee on the, let's see, which one was it? The Legislative Committee on Healthcare. And so it was there. So there is an interim committee report from that is available on Nellis that I would encourage our members to also reach out and look at there. There's a work session document that has some of this in the minutes from the discussion of this bill as well. So if you do have some further questions, I would encourage members to do that as well. And it looks like.
Well, I'll just say that because I think that's an important point, but I also think it's important to note that the legislative record that we create in committee is the legislative record, that we don't have a precedent for referring to interim committees and the work that they do is legislative record. So that's helpful for us, but the only formal actions that we take are when we're in session. So I always think it's helpful to mention, ask these kinds of questions for the records because if you don't ask how it's going to get done, this is the only place where bodies, boards, the people who write regs can look back for direction.
I don't disagree, and I'm not discouraging questions and creating a legislative history. I just wanted to make sure the members knew that. I know that it was left out during the introduction of the bill, and I know that the interim committee wanted to make sure that that was also included on the record in case people had some additional information that they wanted to look at some of those other discussions that were had during that interim. But again, I would encourage anyone to ask questions and create that legislative history, because I do agree that we do need to have the intent clearly on the record. Do we have any other questions from committee members at this time? Seeing none, we will begin testimony in support of Senate Bill 379. I will look here in the room to see if there is anyone, and I see Senator Ratty. Please state your name and begin when you are ready.
Thank you. Thank you so much, Madam Chair. I appreciate it. I will be very brief. My name is Julia Ratty. I represent Senate District 13, and I was the vice chair of the Interim Committee on Healthcare. It was chaired by Assemblywoman Leslie Cohen. This particular item came forward specifically because of an experience with one of our federally qualified healthcare centers in Washoe County. They had been able to use one of the wonderful programs from the federal government to do loan repayment to some of their healthcare professionals. And unfortunately, because Nevada didn't have sufficient data to be able to compete well, when the next time came around to renew that kind of a program that helps us to recruit healthcare providers, and specifically healthcare providers to serve low-income and underserved populations, we didn't have the data, we didn't compete well, and we lost that program. So I just want to underscore that this is not just about collecting data, but is absolutely about collecting enough data to be able to compete well and to know where we need to invest our resources and energy, but also to be able to draw down some federal resources so that we can recruit providers, particularly to hard-to-serve communities. Thanks so much.
Thank you, Senator Ratty. Do we have anyone else in the room to testify in support of Senate Bill 379? Seeing no one coming up to the table, do we have anyone on the Zoom that is here to testify in support of Senate Bill 379? If you are, I would ask you to unmute and begin your testimony. I don't see anyone there in support. Yes? No? Okay. At this time, Broadcast Services, can we go to the telephone lines to see if we have any callers in support of Senate Bill 379?
To testify in support of Senate Bill 379, please press *9 now to take your place in the queue. Caller with the last three digits, 672, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Wynn and Assembly Committee on Health and Human Services. For the record, my name is Joelle Gutman Dodson, JoelleGutman-Dodson, and I'm here today representing the Washoe County Health District. We wanted to thank Dr. Packham and Senator Hardy for staying the course with this bill throughout the sessions. We're really pleased that it's back this session. Like the good doctor said, knowledge is power, and the more we know about where providers are and aren't, the better we can work to serve our communities. We believe this will help health outcomes in Nevada and therefore improve the public health of Nevadans. Thank you for allowing me to testify, and we urge your support. Thanks.
Thank you. If we can go to our next caller in support.
Caller with the last three digits, 200, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair and members of the committee. For the record, Bradley Mayer, BradleyMayer, partner at Argentum Partners, representing the Southern Nevada Health District today. And just to echo some of Joelle's comments, really want to thank Dr. Hardy and Dr. Packham for bringing this bill forward. We think collecting this data can have a meaningful impact on how we deliver healthcare in Nevada. And so we would urge your support of this bill, and I thank you for your time.
Thank you. If we can go to our next caller in support.
Chair, there are no more callers in support at this time.
Thank you. At this time, I will begin testimony in opposition to Senate Bill 379. Is there anyone in the room? Seeing no one, is there anyone on the Zoom? Don't see anyone there. Broadcast Services, if we can go to the line in opposition testimony.
To testify in opposition to Senate Bill 379, please press star 9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
Okay, next I will go to neutral. Is there anyone in the room to testify in neutral on Senate Bill 379? Seeing no one, is there anyone on the Zoom? I think we have maybe someone on Zoom. Go ahead and unmute and begin when you're ready.
Thank you. Hi, my name is Kyra Morgan, Kyramorgan, and I'm the state biostatistician for the Department of Health and Human Services. I just wanted to provide a little bit of clarity on data collection and that piece. The idea behind data collection is that the survey would be created and maintained by DHHS. My office would be involved in that process. And then a simple web link to that survey would be provided to the health professionals upon renewal of their licenses. And I think this is an important piece of clarity because it really would just require, from a technical perspective, for the person renewing their license to have access to either a computer or smartphone in order to be able to follow that link and complete the survey. There really is no technical requirement from the perspective of the survey distribution on behalf of the boards, with the exception of just making that link available to their members. The data would then be submitted via an individual following that link. They would be taken to a page to complete the questionnaire, and the responses to those questions would be directed back to DHHS, the Department of Health and Human Services, without actually having to be received by the boards themselves. And so I think that not only eliminates a lot of workload from the perspective of a technical requirement on the boards, it also, I think, eliminates concern that those responses could be used in any kind of negative way in regards to confidentiality of the data. So I just wanted to make those points of clarification, and that's all I had. Thank you.
Ms. Morgan, if you could just hold on one second. I want to see if our committee members have any other follow-up questions for you specifically, and I appreciate you trying to answer some of those questions preemptively. Do we have any follow-up questions for Ms. Morgan?
Thank you so much. I appreciate that, Madam Chair. So I think I heard a piece that was important, which was you're just the responsibility of the board will just be to make the link available to their licensees. So, and that's a good distinction because what I was trying to figure out is, okay, our board's going to have to stand up an electronic web base, and some are moving there and some aren't. So would we inadvertently be causing some of these smaller boards to have to really get their tech in line, which typically just means more licensing fee increases, which are fine. If you need them, they need to go there. But, was that going to happen in the time frame that this implementation date was looking at? So as long as they provide the information to their licensee, which could include a little piece of paper, a little notice in their renewal notice, then the board has met their obligations on their part for this legislation.
Kyra Morgan, for the record, that's correct. The idea with us maintaining the survey would be that we would take the burden away from the licensing boards. We would cover the technical aspect of that, and then anyone with access to a smartphone or computer would be able to follow that link and submit their data directly to DHHS.
Thank you, Ms. Morgan. I think I have another question from one of our committee members, if you could continue to stay on the line. Assemblywoman Summers Armstrong, go ahead.
Thank you, Madam Chair. Ms. Morgan or Ms. Dodson on the line. We know that I'm learning today that all of the boards do not have full capacity web capability. But will the link also be available somewhere on their websites, even if they don't have the ability to have an online renewal? I heard my Assemblywoman Benitez Thomas speak about a piece of paper, but often people will just go to websites to look up stuff. Is that possible, and will you all be able to help those boards maintain that link to make sure that it's fresh and functional, in addition to any physical papers that they might share with their board members?
Yeah, Kyra Morgan for the record with the Department of Health and Human Services. Similar to what Dr. Packham stated earlier, there are a number of ways that we can accomplish this, and I think the bill keeps it broad as to not prescribe exactly how it will be done, but absolutely yes. Once the survey is created and a link is provisioned, then that link could be distributed via an email listserv, it could be printed in hard copy, it could be posted on a website. There are a number of ways that could be distributed, and typically from the technical perspective, how that works is as we update the survey, as long as we keep it at that link, maintenance as far as where that link is stored is extremely minimal. And so the short answer is yes, but we don't have the exact details worked out. There are a number of mechanisms we could utilize.
Thank you, Ms. Morgan. Do we have any other questions from committee members? Seeing none, if we could go back to the Zoom for any other additional testimony in neutral of Senate Bill 379. I see Ms. Chappell on there. I don't know if you would like to provide neutral testimony, but please go ahead if you would like to.
Thank you, Margot Chappell. For the record, I just want to go on the record saying that this data is important to the HPSA designations that our office is responsible for periodically for the Health Resources Services Administration at the federal level, and it will greatly assist us in creating that data and reporting it more easily on a regular basis. Thank you.
Thank you. And do we have anyone else on the line in neutral? Seeing none, Broadcast Services, do we have anyone on the telephone line in neutral?
To testify in neutral to Senate Bill 379, please press star 9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you. And with that, I will turn this back over to Senator Hardy for any closing remarks.
Joe Hardy, Senate District 12 for the record. I was saving this for the very last on purpose. This is a committee bill. Came out of the interim. And Senator Ratty is really the one responsible for it. And so I don't want to claim any responsibility or any accolades because all of this was committee work and Senator Ratty's fingerprints are all over it. Thank you, Madam Chair.
Thank you. And with that, I will close the hearing on Senate Bill 379. Next, we will move to Senate Bill 391. And I will open that hearing. Welcome Senator Ratty back to Assembly Health and Human Services. She is here to present Senate Bill 391, which revises provisions relating to dentistry. Please begin when you are ready.
Good afternoon, Assembly Committee on Health and Human Services. I've missed you so. My name is Julia Ratty, and I am here representing Senate District 13, but today actually sitting here more in my role as the Vice Chair on the Interim Committee of Healthcare to bring forward to you another Interim Committee on Healthcare bill that passed out of that committee unanimously. This particular bill has been through quite the journey. We recognized Chair Cohen and myself recognized at the beginning of the interim that Nevada has significant struggles when it comes to oral health care. And we asked for the committee to focus. The committee really chose a couple of buckets to focus on, and we chose oral health as one of the areas that it was appropriate for us to focus on because of the significant negative outcomes in Nevada when it comes to oral health care. And so as part of that, I don't know if you all know that we have a state dental health officer. I did not know that we had a state dental health officer until last session when I did a little bit of work in oral health. And so we went to our state dental health officer and said, can you help us with a survey sort of across the nation of best practices when it comes to oral health and places that we could move the needle in when it comes to oral health care. And Dr. Antonina Capurro did some phenomenal work where she brought us forward a package of things that we could consider. And we had a couple of good days of hearings on oral health in the interim. Unfortunately, then there was a pandemic, and coming into This legislative session, we knew that we probably would not have very much success with anything that had a significant fiscal note. And so during the interim, as we got to the work session, we pared that list back significantly and really eliminated most of the things that had a fiscal note, knowing that this just wasn't the time to be looking at significant expansions of program or services. So what we were left with were two very important pieces where we could move the needle on oral health care. One is focusing on oral health professionals, the whole spectrum, whether it be a dental hygienist, a dental therapist, or a dentist, and their role in response to an emergency. So one of the things that we learned during the pandemic is that we had this whole field of professionals that could lean in, but that actually when it comes to oral health, we have very little infrastructure built in terms of an emergency management structure. Very little training, very little identification of who's available and how they could be available, and that was something that we needed to rectify. So that was the first piece. And the second is that our state NRS lags when it comes to the concept of teledentistry. So we've done a lot of work in this legislative body over multiple sessions on telehealth, and telehealth has seen a dramatic expansion and acceleration of acceptance during the pandemic, but we hadn't done a lot of work on teledentistry, and so we wanted to update the statutes when it came to teledentistry. So to be very clear and transparent, those are the two concepts that came out of the interim healthcare committee, and you will see in the bill, and I'm going to ask Dr. Capurro to walk through those sessions because frankly, most of it is her work that she helped support the committee to work through. Since the interim, I've had a couple of conversations with Richard Whitley, the Director of Health and Human Services, about some of the challenges for recruiting the state's own dental health workforce. So these were not parts that came out of the interim committee, but things that got added on afterwards. So we have two staff in the state of Nevada who support dental health. One is our dental health officer. Dr. Capurro is that person. And the other is a public health dental hygienist that works for the state. They were structured very differently in statute than their comparable peers. So for example, the dental health officer was structured very differently than the chief medical officer, specifically when it comes to licensing. And so we addressed the licensing for the chief dental officer to make it more comparable to the chief medical officer. And then specifically to the state dental health, public health hygienist, there's a piece in state law that says that if you work as the state public health hygienist, you can't take any outside work. And that typically makes sense with our state employees. We say that, if you're going to have a full-time job with the state, you probably shouldn't be doing any outside work, with the exception that our public health dental hygienist is a part-time position because we haven't had the resources to fund it at a full-time level. And so to recruit somebody into that position, you're basically saying, hey, we'd like to hire you for a part-time job, and you're not allowed to do any other work to be able to pay your bills, which is just impractical on its face. So I'm going to take you through the parts that are very specific to the oral health staff, because I don't think it would be appropriate to ask Dr. Capurro to do those pieces, since she is one of those team members. And then I'm going to ask Dr. Capurro to take you through the very specific sections about telehealth and emergency response in the oral health community. So if you look at the bill, Section 1 of this bill requires that the dental health officer is not required to be a licensed practitioner. And again, this is a position that's not sitting in a clinic and doing dental health work on most days. So that license is not necessarily appropriate. Instead, it allows for they could be a licensed practitioner, so that's one option, but it allows for an alternate option, which is that they would have a master's in public health and have graduated from a CODA-approved dental health college. So they would have completed their dental health education in a CODA-approved educational facility and would have a master's in public health. This would allow for recruitment from, say, somebody who's been working in academia for a while and is no longer using their practitioner's license and just hasn't updated that license. It will allow for much greater ease of recruitment from out of state. So when a dental health officer would come here, they would be able to get this license that is basically specifically created for our dental health officer. So you're going to find that in Section 1. Section 1.3 is the section that removes the prohibition on the dental hygienist from having outside work. Again, that is the position that is part-time position now, and I think it's only fair that that person allowed to be able to have other outside work. And then the Section 27.5 is the section that authorizes the Board of Dental Examiners to issue this limited license for the dentists and dental hygienists as applicable. 27.5 prohibits the holder of a limited license from practicing dentistry or dental hygiene as applicable. And Section 39.5 requires that it be renewed annually, and 40.5, 39, 40, and 41 all make the conforming changes. So I will pause there, because those are the sections of the bill that specifically relate to the licensing of the dental health professionals, and ask, Madam Chair, do you want to do questions and answers on that piece only, or would you like Dr. Capurro to go through the teledentistry and emergency response sections of the bill, and then we can do questions globally?
We'll do questions at the end.
Okay,
That would
great.
work.
So those are the highlights of the our dental health workforce for the state, and I'll turn it over to Dr. Capurro and ask her to walk through the teledentistry and emergency response sections.
Thank you, Senator Ratty. Good afternoon, Chair Nguyen, honorable members of the committee and committee staff. For the record, I'm Dr. Antonina Capurro, State Dental Health Officer, overseeing the Nevada Oral Health Program within the Department of Health and Human Services. I'm joined this afternoon by Ms. Jessica Woods, who is our interim state public health dental hygienist, and she can also provide additional details on this bill. I just wanted to kind of start with a little bit of background that the landscape of healthcare is changing as our service delivery models. And so to adapt to these changes and implement lessons learned from the dental community's response to the pandemic, this bill has been created. And the components of the bill are built on the foundation that oral health is critical to overall health for individuals of all ages, that poor oral health can lead to pain and tooth loss that affects quality of life and can impact employment. Research has identified that associations between poor oral health and chronic disease conditions such as diabetes, heart, lung disease, and stroke. However, in 2019, what we saw was 35.3% of Nevadan adults reported they had not visited a dentist or dental clinic within the last year, and 23% of Nevada adults respond that they experience anxiety due to the conditions of their mouth and teeth. We know that low-income adults, individuals and families, as well as racial and ethnic minorities are disproportionately affected by oral health problems. And the COVID-19 pandemic has aggravated these healthcare inequities. It's led to dental office closures to all but emergency services from March 16th to May 4th. We had a cancellation of school-based preventative touch points, and there's also been a change in the dental workforce, which we may not realize for several years. So many of the lessons learned from providing dental care during the pandemic, including the expanded use of teledentistry and inclusion of dental professionals as emergency responders, is addressed in this bill. Section 10 to 16, I'll walk you more in detail through these two components of teledentistry and dental emergency responders. First is the dental emergency responder portion. So section 10 through 16 defines the educational and training requirements that are needed for oral health professionals to respond to a public health disaster or any type of state of emergency. And it also establishes the Committee on Dental Emergency Management. This section is based on the concept that emergencies and disasters strain the state's health resources, and without a more robust disaster workforce, the lives and well-beings of Nevadans are at risk. And dental practitioners who are well-versed in emergency management are a deployable healthcare professional during a public health crisis or a terrorist threat or a natural disaster. There are numerous dental professionals who are technically trained to save lives, but who do not have the specific types of training that would be necessary to step in during an emergency or public health disaster. And This lack of training impairs the state's ability to respond quickly and efficiently to emergencies and disasters. And so this training is addressed in this section. And Section 17 adds a dental emergency responder to the Committee on Emergency Medicine Services. The last component in the bill is teledentistry. So just as a little bit of background, during the 2020 stay-at-home orders, there was an exponential rise in the number of teledental visits. June 2019, there were roughly 102 teledental visits for Medicaid patients. That number grew to 934 in May of 2020. And this increase occurred without a framework for safe and efficient utilization of teledentistry. The section 19 to 21 includes a teledental exam that meets certain criteria as an option to fulfill school entrance requirements. Section 22 to 27 defines what teledentistry is. Section 28 to 31 requires a dental practitioner to follow clinical requirements, ethical standards, and confidentiality of the patient's information during a teledental visit. It also outlines the practitioner-patient relationship and outlines informed consent as well. Section 32 to 35 ensures communication complies with all HIPAA laws and the patient information is secure and encrypted. Section 33 outlines when referrals should be made to ensure that there's adequate in-person care when it's needed. Section 34 requires the Nevada State Board of Dental Examiners to adopt regulations governing teledentistry. And Section 37 and 39 outline a one-time teledentistry educational course for dental practitioners. Section 1.7 and Section 42 to 45 creates options for hospital systems in the state to use the established network of dental professionals that are enrolled in the Dental Managed Care Organization to bring those teledental services to individuals that are having a real-time dental emergency at a hospital. Section 19 to 39 then and 42 to 45 are the sections that establish this framework for teledentistry to reduce those traditional barriers to care, to foster equality, and allow Nevada to leverage new technologies that expand access to dental care for all patients in the state, regardless of where they're located. Parity with in-person services, practitioner-patient relationship, informed consent, patient record requirements, confidentiality of the information, referrals, and regulations to be created by the Board of Dental Examiners are all outlined in these sections. Senator Reddy, I'll turn it back to you.
Thank you very much, Dr. Capurro. Again, Senator Julia Ratty for the record. I believe that is the entirety of our presentation, and we stand ready to answer questions.
Thank you. We have a couple of questions, I think, here up on deck. So if we can go first to Assemblywoman Titus.
Thank you, Madam Chair, and thank you, Senator Ratty, for bringing this bill forward. As a city member of I was a member of the Interim Health Committee. However, we never see the bills actually written. It was also a general concept of what our priority is going to be for bill presentation. So I have a couple questions on the bill. Under Section 1, number 1 and 2, where you're actually removing the requirement that they be a licensed dentist in the state. So at no time then can our dental health officer see patients, practice on anybody, give advice, consult, and so you're removing them from their ability to practice, or will you ultimately require that they get a license in the state? Because I understand that perhaps you want to recruit somebody, they're not currently licensed in Nevada, and there may be a delay. So I certainly understand that you may be able to recruit them and not have them licensed at the time, but I'm concerned that ultimately they may never need a license to practice in the state.
Thank you for the question, Senator Reddy, through you, Chair Wynn, to Assemblywoman Titus.
Senator Reddy, feel free to go directly to the member.
I appreciate that, Chair. Thank you so much. So Section 1 creates the alternative path to licensure. So that's where you see the or. So right now it has to be somebody with a current license to practice, and the Section 1 sub 2 creates the alternate pathway, which is the doctorate degree in public health or a master's or a doctorate degree in public health or a related field, and be the graduate of a dental college or residency program accredited by the Commission on Dental Accreditation, which I think you know through all those hearings is the accrediting body for educational institutions for oral health. Then if you would follow me to page 19, and now we're looking at section 27.5. This is the section where the board shall, without the clinical examination required, issue the limited license to a person to practice dentistry or dental hygiene who, and so if you follow that on to page 20, it's a person who's entered into a contract with the state dental health, to serve as the state dental health officer or the hygienist, satisfies the requirements of those chapters, pays the fee, and then it talks about the limited license, how you get that license, how the fee, and then if you go to 5, which is line 19, shall not for the duration of the limited license engage in the private practice of dentistry or dental hygiene in this state or accept compensation for the practice of dentistry or dental hygiene in this state, except such compensation as may be paid to the person by the Division of Public and Behavioral Health, etc. So I think you see it there. Only within the scope of his or her appointment as the dental health officer or the dental hygienist. And then 6 is important, not later than 7 days after the termination of the contract. So now they are no longer an employee of the state. Provide written notice of the termination to the board and surrender the limited license. So if they were interested at that point in going back into practicing dentistry, or maybe practicing dentistry for the first time in the state of Nevada, they would have to apply for and obtain their license to practice. So I hope that that answers your question. It's the combination of section 1 and section 27.5 that lay out what the new path is and what the requirements of that new path are.
Thank you for that follow-up, Madam Chair. So,
Go ahead.
And thank you for that clarification. Another question on section 1.7. You say that if a Medicaid recipient presents to the emergency room, there's a list of dental providers that must be given to them or displayed somewhere. Is it, in my practice, we always made sure everyone, those who weren't on Medicaid, those who were uninsured, underinsured, insured, et cetera, had follow-up instructions and had access to lists of providers that we would refer them to, whether it was the ophthalmologist, whether it was the orthopedist, and all of the above, including a dentist. And I'm worried that, why are you signaling out that the Medicaid recipient has to have this list and it has to be posted?
Thank you for the question, Assemblywoman Titus. Great question. I will turn that one over to Dr. Capurro. There were many conversations with providers that resulted in some compromised language, so she had more involvement, so I'm going to ask Dr. Capurro to take that one.
Thank you for the question, Assemblywoman Titus. For the record, I am Dr. Antonia Capurro. So this language specifically talks about Medicaid recipients because that is the patient pool that we have that we know that services are provided for this when they come in. I'm sorry, so sorry. Let me kind of back up. So when they come in for a non-traumatic dental emergency, right now, somebody that's seen at the hospital, there's no definitive treatment that's provided. And so providing teledental services to that group will ensure that they're able to access real-time care. And those services are provided under Medicaid. And so that's why this language has come about, so that there's some type of information when they're in the hospital emergency room and they don't go from that emergency room back to the emergency room when their condition flares up again. Adults in the state have dental coverage for emergencies, but we are trying to link them to a provider. And so that's why this is more specific to the Medicaid patient. But I would hope that if the hospital had some signage about teledental providers or the use of teledentistry, that any patient in the hospital would become aware of that and would use those services.
Thank you for that. And just a clarification, I just want to make sure that the Medicaid patient isn't seen as getting lesser care because they're forced to use the teledentistry, whereas another patient might be referred right to the dentist. And so I'm just an in-person visit. So I just want to make sure there's parity there, that it's just not Medicaid, well, you're on Medicaid, so now you have to do this teledentistry. There's actually I'm just always anxious when a certain subset is provided one avenue and not everybody else is provided that avenue or the reverse. So I needed some clarity that indeed somehow or other this helped care for all patients, and I'm just not seeing that. So thank you, Madam Chair.
May I?
Thank you. Yes.
May I address the question?
Please respond.
Oh, for the record, I'm Dr. Capurro. So we are not trying to change what is provided in the hospital. All patients would still have to be triaged in the hospital. This is simply a referral mechanism to ensure that those patients that have this Medicaid benefit are able to receive it. So it's a type of care coordination.
All right, thank you, Madam Chair.
Thank you. Are there other questions from the committee?
Vice Chair, if I could just
Yes,
jump in
please
and
go
address
ahead.
that. So having served on many health committees with Assemblywoman Titus, I know where she's going with that line of questioning, and I would, again, Julia Reddy for the record, I would be happy to look into it a little bit further. I will say that the origin of this is we've set up a whole dental provider MCO within the state, which I know that you're aware of, and we see underutilization. So what's happening is, for whatever reason, our Medicaid patients are not figuring out that they also have dental insurance. And so I don't know that we see that same problem for somebody who has their own insurance, knows about their insurance, but we are definitely seeing in the Medicaid market a significant underutilization of a service that we're investing a significant amount of resources into. So this is really trying to get at that underutilization of our Medicaid dental health benefit. But I'm happy to take a look at it if we need to expand the language that anybody who has a dental emergency should get this list. I think that will happen naturally, but that's the genesis of this, if that's helpful for context.
Thank you, Senator. Much appreciated and very clear. Thank you. And thank you, Madam Vice Chair. And I see the chair is back, so thank you.
No problem. If we can go next to Assemblywoman Thomas.
Thank you, Madam Chair, and thank you, Senator Ratty, for bringing forth this SB 391. My question is basically a question of clarity or understanding. I've started reading in section 10 through 16. And when I got to section 13 and subsection 5, and I'm not understanding, where it says a dental responder may not be held civilly or criminally liable for any act or admission performed while providing or supervising the provisions of emergency medical care, immunization, medical care in a mobile clinic, or humanitarian care in accordance with this section and the regulations adopted pursuant thereto, unless the act of or omission. And then it just goes down to 5 subsection A, amounts to willfully misconduct or gross negligence. And I wanted to know who determines what is willful misconduct or gross negligence, because I'm not seeing where the patient in this who's under the care of a dental responder has the ability to tell authorities that they feel like there was misconduct or negligence. Thank you.
Thank you. Great question. Again, Julia Ratty for the record. So it is my belief, and I don't believe we have legal counsel with us today, but I feel relatively confident that this is the boilerplate language that is in place for all emergency response. And so it acknowledges that in an emergency response, sometimes our providers are going to need to take emergency action, and we try to give them some protection, a limited protection from liability, if they are operating within good faith, within the scope of their license to provide assistance to somebody in an emergency. So that's the first sort of premise. Specifically getting down to the exceptions to that, and these are very important exceptions. So this is not a get out of civil court or get out of criminal court free card, and going back to my Monopoly days, I guess. So it does not amount to that at all, because if there's been willful misconduct or gross negligence, or they were under the influence, you lose that liability protection, if you will. Now, I will just say, I try to stay out of the Judiciary Committee as much as possible, because there are lawyers on our members of all of our caucuses who really know this significantly better than I. But at the end of the day, the decider will be the judge, right? Because really this is about if there were a criminal charge filed or if there were a civil complaint. So that patient, if they had perceived that they had been harmed, their remedy would be to file a civil complaint. And then the judge would look at that civil complaint, and the judge's starting point would be, well, they have some limited immunity here because it was an emergency, but if they were under the influence or it meets the standard of willful or misconduct or gross negligence, which are legally defined terms that courts are accustomed to working with. So this is really all about that system, the court system, and the court, and specifically the judge would be the person who would decide. And please, Chair Nguyen, feel free to bail me out if that is not an accurate reflection of the court system.
I was going to just indicate that Ms. O'Krent is actually on the Zoom right now.
Okay,
She
good.
has been available, and I will turn it over to her to clarify or confirm what you had just mentioned. Go ahead, Ms. O'Krent.
Carly O'Krent, for the record, that's absolutely correct. It would be up to the court to make a determination regarding whether willful misconduct occurred, and willful is defined in Black's Law Dictionary to have a particular meaning, so that would be interpreted by the court at that time.
Thank you. So with this, it doesn't, to me, it looks like that a patient does not have the ability to seek restitution for what they feel might be, just the way it's worded here to me. That's just my opinion. Thank you.
Thank you. I appreciate the clarification and the perception. Again, Julia Reddy for the record. Again, it's relatively standard language that we have, I think, in all of our emergency response, and I just want to be very clear. It's not my intent that we are removing a patient's right to seek remedy. They absolutely have that right to seek remedy. They would only achieve that remedy if there was willful misconduct or gross negligence or somebody was under the influence. That would be, that I think is the way to think about it. Thank you for the comment.
Assemblywoman Thomas, do you have any other follow-up questions?
No, ma'am, I appreciate it. Thank you.
And I'm looking around. Do we have any other questions from committee members? Okay. Go ahead, Assemblywoman Summers Armstrong.
Thank you, Madam Chair, and thank you, Senator Ratty, for this presentation. If my memory serves, we had a bill just yesterday in the judiciary that talked about removing the dental board. And I'm trying to figure out consolidating, I think, some of the boards. And that was really surprising, so I actually texted my doctor, my dentist, to ask if he knew anything about it. And how would this affect, how would this, how's this going to bookend into that?
Thank you for the questions, Assemblywoman Julia Reddy, for the record. So I have not in a position to answer that question in that it was not my bill, and I have not sat on the committees who have heard that bill. So I can't claim to be familiar with it in a detailed way. I think legal counsel might be best, again, to chime in that what happens if two bills pass that are in conflict with each other. We certainly have lots of statutes that call out the licensing boards. And if there's a change to the licensing boards, my assumption would be that all of the other statutes would have to conform to that, but.
Ms. O'Krent, I see you back on the Zoom. Is there any clarification that you can give to Assemblywoman Summers Armstrong at this time, or do you need some additional time to research those two bills? And
Carly O'Krent for the record. I would need some additional time to research the specifics of that bill, but Senator Ratty is absolutely correct. In the event that a bill passes and is enrolled that conflicts with another bill, our office has a review process whereby we ensure that substantive conflicts are not passed without being addressed during the legislative session.
Assemblywoman, do you have any follow-up questions?
No, thank you.
And I think I saw Assemblywoman Benitez Thompson down there, or was it Assemblywoman Krasner? Assemblywoman Krasner, go ahead.
Thank you, Chairwoman, and thank you for your presentation. I'm just looking at sections 19, 20, and 21. We're talking about teledentistry and dental homes and virtual dental homes. It talks about public schools, private schools, and child care facilities that require children to receive dental examinations. And then it says that the dental home, which is a group of people, including a dentist, can have a virtual dental home, which means that it just has to be a dentist that's licensed in Nevada. And I'm wondering, can it be a dentist that's licensed in Nevada but actually living and has their practice in, say, Florida or some other state or country?
Thank you for the question. Senator Julia Ratty, for the record, I'm going to turn that one over to Dr. Capurro. I think we've, again, learned a lot about telehealth just generally and what can and works well, but I'll turn over the details of that one to Dr. Capurro.
Thank you for the question. For the record, I'm Dr. Capurro. It is specified in this bill, and I'm looking for the section, I think it's section 28, that a person that provides teledentistry would need to be licensed in this state. So they would need to be licensed in Nevada. And so the virtual dental home model, what I've seen in other states when they have a virtual dental home model, it's more a patient who doesn't have, maybe they're living in a rural community, there isn't a dentist near them. And so they're receiving care via the teledentistry with that licensed provider in the state that they're living in. And there's also language regarding informed consent that determines that the patient is in the state the dentist is practicing in. I hope that answers the question.
Just a quick follow-up. It kind of does. So because they can have a virtual home, and I could be wrong, I think that dentists can be licensed to practice in more than one state. Is that correct? So if that's true, could the dentist be licensed in, say, Nevada and Florida both, and then they have a virtual home in Nevada where they do these teledental exams on the children, but they're physically located in a different state? Is that possible with this bill? Thank you.
Thank you for the question, Dr. Capurro, for the record. I would say that I guess technically if the provider is licensed in multiple states but is also licensed in Nevada, so they're following Nevada statutes and laws, then that would technically be possible. But the provider would also need to provide referrals, so that's also outlined in the bill. So if the patient needed care that the dentist could not provide through teledentistry, they have to be aware of the surrounding provider network and refer the patient to care. So the child would not be without a referral network if that was the case.
May I add something? This is Jessica Wood, interim state hygienist. I've worked in this model before, so one thing that might be helpful as a visualization is to think of this as kind of like a hub and spoke model where the dentist may be in one location, but then other members of the dental team, like a dental hygienist or a dental therapist, would be out in, say, a rural community. And so they are collaborating with that dentist to give them kind of the oftentimes the dental hygienist or the dental therapist will be collecting some sort of information, whether it's x-rays, intraoral pictures, and sending it back to that dentist who's not actually in that community, maybe not even in the state, but giving the direction to a provider that is actually located there as well. So that this language would allow for that as well, just to kind of piggyback and add some additional information.
Thank you.
And again, Julia Reddy, for the record, the only piece that I would add to that is that it does end up actually becoming critically important for a state of Nevada that has so many of our communities that are right on the border. And so if you think about some of our eastern Nevada communities where a good chunk of their care might come from Salt Lake City, or our southern Nevada communities where a good chunk of their care might come from across the border over in Arizona, or right here where we have some good relationships with our California providers. Yes, the model is intended. There's nothing in the bill that prohibits that virtual home from being outside of the state.
Thank you. I'm looking around. I know that there were several questions, but I believe other people asked those questions and they were answered, but I'm just doing one more round around here. Okay. Seeing no more questions at this time, we will begin testimony in support of Senate Bill 391. If we can go to anyone in the room, I'd ask you to approach the table, state your name, and please limit your testimony to 2 minutes.
Thank you, members of Assembly Health and Human Services. For the record, my name is Eddie Ableser, EDDIE-ABLESER, representing the Nevada Dental Association this afternoon. Thank you all for hearing the bill and the testimony as provided by Senator Ratty. We want to extend our appreciation to Senator Ratty for sponsoring and bringing the bill out of the interim, the hard work that was done in the interim on this topic, and thank Dr. Capurro for her efforts in bringing these much-needed pieces of policy before you. We ask for your full support on the bill as on behalf of the dentists throughout the state of Nevada. Thank you for hearing this and appreciate your time.
Thank you. Do we have any other individuals in the room to testify in support? Seeing none. Do we have anyone on the Zoom? I don't believe we do, but if you are here to testify in support, I'd ask you to unmute. Seeing none there. Broadcast services, if we can go to the line.
To testify in support of Senate Bill 391, please press star 9 now to take your place in the queue. Chair, there are no callers in support at this time.
Okay, if this time we can start opposition testimony. Is there anyone in the room to provide opposition testimony? Seeing none, is there anyone on the Zoom to testify in opposition? Don't believe we have anyone. I don't see anyone. And broadcast services, if we can go to the line in opposition.
To testify in opposition to Senate Bill 391, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 337. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Dr. Vilas Sastry. Sorry, I was trying to figure out the navigation of the unmute mute. I'm the CEO of teledentistry.com, and I actually am in support of this bill. I just wanted to give a call and thank you to all the members on the call, as well as Senator Ratty, as well as Dr. Anthony Capurro for putting together this legislation, and wanted to offer my full support for it. Thank you so much.
Thank you. And Madam Secretary, I know people occasionally have technical difficulties. If we could reclassify that as support testimony. Do we have anyone else on the line in opposition?
Caller with the last 3 digits, 205. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last three digits, 205, please press star 6 to unmute. Caller, you appear to be unmuted on our end. Are you muted on your phone?
Hello. Good afternoon. This is Dr. Palaracio. For the record, my last name is Paleracio, and I am a licensed practicing dentist in Nevada and at the same time president of Las Vegas Dental Association. I am here to oppose SB 391. The state dental health officer needs to be a qualified Nevada licensed dentist. The state dental health officer needs to have passed clinical exams to be able to understand the oral health needs of Nevadans. The public citizens of Nevada are not protected when the state dental health officer is not capable to diagnose patients and has not been trained clinically to examine patients. The current state dental health officer, Antonina Capuro, earned over $200,000 last year in public positions. The current state dental health officer, Antonina Capuro, is under investigation for the illegal practice of dentistry and violating the terms of her license, which states she was graduated on the condition that she would then practice clinical dentistry. SB 391 proposes to change the law that the state dental health officer doesn't need to be a Nevada licensed dentist, thus allowing Antonina Capuro to keep her very highly paid job, earning over $200,000 per year, and then forcing the dental board to give her a dental license. SB 391 further changes the law that the state dental hygienist officer would be allowed to work outside of her state position. The current state dental hygienist officer is already working outside of her position, thus possibly violating current state law. Why would the Nevada Legislature, who are responsible for protecting the citizens of Nevada, propose SB 391 to have an unlicensed and unqualified individual be the state of dental health officer? It seems to me that this bill has been designed in order to protect someone. Thank you very much. And for the record also, I am a long-time Medicaid provider, and there's a lot of problems that we encountered. And I would be glad to testify during legislative committee if there's a need. And I would like to discuss the big disparity of a dental care under Medicaid program. I would love to receive any telephone calls from any of our legislators. Thank you so very much.
Thank you. If we can go to our next caller in opposition.
Chair, there are no more callers in opposition at this time.
Thank you. And at this time, I will go to any neutral testimony. Do we have anyone testifying in neutral in the room? Seeing none. Do we have anyone on the Zoom to testify in neutral?
To testify in neutral to Senate Bill 391, please press star 9 now to take your place in the queue.
Good afternoon, Cody Finney from the Division of Healthcare Policy and Finance. I just would like to go on the record as saying that Dr. Capuro's help for the Nevada Medicaid program has been greatly appreciated. Having that clinical experience for our policy development has been a great boon to us in trying to improve our dental policy and our dental programming, and we appreciate the help. Thanks very much.
And Broadcast Services, do we have anyone on the line to testify in neutral?
With the caller with the last three digits, 337, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, this is Dr. Vilas Sastre again, CEO of teledentistry.com. I just wanted to speak in support of Dr. Capuro and everything that she did last year with regards to how
I think you've already
provided guidance to us.
Excuse me. I think we've already heard your testimony on this bill in support, and we've already reclassified it. If you have any additional comments, I encourage you to wait until public comment.
Understood. Thank you so much. All right.
Broadcast Service, do we have anyone else in neutral?
Chair, there are no more callers on the line in neutral at this time.
Thank you. And with that, Senator Reddy, if I can bring you back up to make any closing remarks.
Thank you, Madam Chair. I appreciate the opportunity. First of all, I just want to let the committee know that nobody has contacted me with any concerns about the bill directly or asked for any conversation or any changes to the bill. So sitting here in the hearing today was my first knowledge that there were any concerns. None of this came up on the Senate side either. I would also like to note that the changes in the bill with regard to the current health staff are neutral and not intended to be specific to any one individual. They came about because of a conversation that I had with the director about the challenges for these particular positions. And again, the chief dental officer position, this aligns it very similarly to what we do with the chief health officer. And I think that there are some very legitimate reasons as to why we would want to do that. I am disappointed that anybody wants to make this about anyone individual or personal, and just would give you my assurance as the chair that this is about good policy and is about nothing more than that. So with that, I know that there were some questions and concerns. If there's anybody on the committee that is looking specifically for an amendment that they would like to this bill that would help you to support it, I would ask you to reach out to me. We are getting to that point in session where we are running out of time, and there are some good things in this bill that really will help move the needle, be it ever so slightly, not as grandiosely or as significantly that we had hoped during the interim, but it will make a difference, particularly on building that emergency responder workforce and getting some clarity in our statutes around teledentistry. So if you're looking for some amendments, I would ask that you please reach out to me, and otherwise I very much urge your support. We need to do more when it comes to oral health, and these are some good steps forward. Thank you.
Thank you. And that I will close the the hearing on Senate Bill 391, and I will open the hearing on Senate Bill 329. And I see Senator Lang here. Senate Bill 329 revises provisions related to competition in healthcare markets. I believe she is presenting along with several others that are on the Zoom and potentially here in the room as well. So I will let you begin when you are ready.
Thank you, Madam Chair and members of the committee. For the record, I'm Roberta Lang. I represent Senate District 7 in Clark County. And thank you for the opportunity to present Senate Bill 329 before you today. This bill aims to enhance transparency around healthcare consolidation and limit anti-competitive contract practices between hospital systems and health insurers in Nevada. Let me just go over the problem. As you are all well aware, healthcare spending is high in Nevada and nationwide. According to official estimates, total healthcare spending in the United States reached $3.8 trillion in 2019, a 4.6% increase from the previous year. In fact, national healthcare spending has been growing by 4 or 5% annually since 2014. A key factor that contributes to increasing healthcare spending is market consolidation in healthcare providers and facilities. According to a new report from the National Academy for State Healthcare Policy, quote, rampant consolidation in nearly every state has created dominant healthcare systems that use anti-competitive contract practices to charge super-competitive prices, especially to commercial insurance plans, end quote. The COVID-19 pandemic is expected to further accelerate this consolidation. And according to the Kaiser Family Foundation, a large body of research demonstrates that provider consolidation leads to higher healthcare prices for private insurance. Studies also show that consolidation of healthcare facilities reduces health insurers' ability to keep prices low because they have less market power than the hospitals. At the same time, these increased prices have little or no impact on quality of care, utilization rates, or efficiency. Nevada currently does not have many tools to review or regulate consolidation in the healthcare market. We have a pretty high bar before mergers and acquisitions are reviewed by state reviewed by state agencies. Certificate of need laws only apply to certain parts of the state. We do not have any information about the impact of private equity in the healthcare markets, and nothing prohibits contracting practices that favor healthcare monopolies. This bill aims to address these problems by taking the first step to monitor consolidation among healthcare facilities and limiting anti-competitive contracting practices between hospital systems and health insurance payers in Nevada. Joining me to provide additional information regarding the real-world effect of these issues, as well as to discuss the technical details of the bills and amendments, are Stacy Sasso, Executive Director of the Health Services Coalition, Maya Holmes, Healthcare Research Manager for the Culinary Health Fund, Babette Bond, Director of Public Policy for the Culinary Health Fund, and Katie Goodingson, Senior Health Policy Researcher for the Source on Healthcare Price and Competition. And I will exchange seats with Chelsea Capurro with the Griffin Company, who will direct the questioning to the appropriate person. And with your permission, I will turn the presentation over to them.
Thank you. If you can go ahead when you are ready. I'm not sure what order you are going in, but I believe you are here to direct. Is that correct, Ms. Capurro?
For the record, Chelsea Capurro, yes, it is. We'll start with Stacy Sasso from the Health Services Coalition.
Good afternoon. For the record, Stacy Sasso, Executive Director for the Health Services Coalition. We want to thank Senator Lang for bringing this needed bill forward and working with us and other stakeholders on the language and intent. We'd also like to thank Chairwoman Nguyen, Vice Chair Peters, and the committee members for their consideration of SB 329. The Health Services Coalition represents 25 union and employer-sponsored health plans in Southern Nevada, including MGM, Boyd Gaming, firefighters, Metropolitan Police Department, and numerous unions, including the culinary, electrical workers, plumbers, and others. The coalition's main focus is to bring affordable, quality healthcare to our estimated 300,000 covered lives. It's the intent of our member groups to help our participants become good stewards of their healthcare dollars, and in order to do that, transparency is key. At this time, I'd like to turn the presentation over to Babette Bond.
Good afternoon. Thank you for hearing this bill. Thank you, Madam Chair, and the rest of the committee. For the record, my name is Babette Bond. I am the Culinary Health Fund Policy Director, and the Culinary Health Fund is a nonprofit health fund that provides comprehensive benefits for 60,000 members and their dependents, so about 125,000 lives we cover. We're part of the coalition that you just heard about from Stacy, and our labor management partnership includes most of the hotels, downtown casinos, airport food services, and laundries in Las Vegas, industrial laundries. Our priority is to ensure access to high quality and affordable health care in Nevada. For both public and private payers and patients, healthcare dollars are precious and in limited supply. I think you've heard a lot about that this session, as every session. Healthcare is a critical need, though, and so we have to be effective stewards of those monies. So we spend our time trying to find what is the cost drivers, where is there opportunity to improve the system, to reduce price, control price, and increase access, and also educate our members and improve quality. It's kind of like, that's the space that we try to fill in this community. Nationally, as you just heard from Senator Lang, there's been tremendous consolidation in the healthcare industry. Hospital systems are buying other hospital systems. Private equity is buying up doctor groups, including here, and other healthcare entities are consolidating as well. And all the experts are saying that this trend is going to continue, and it's exacerbated by COVID, so there'll be more industry consolidation moving forward. So in Nevada, we have a lot of private or public hospital care already, and we don't know very much about how the industry is changing. We know it's happening. We know consolidation is happening in the markets because we see it in our claims and our contracts. We see it when we see that a hospital system has hired an ER group that now, instead of being owned by ER doctors in Nevada, is owned by a private equity company. We have a couple of experiences of that happening in Las Vegas with the ER group specifically. But there's not a lot of transparency about it for you as policymakers or for us to really understand the trends and the impact on price. And Nevada's just behind on hospital transparency, behind on healthcare transparency in general in trying to identify our policy issues. Price is a primary factor behind our healthcare costs. And compared to other nations, and consolidation and lack of competition is a major high price issue. So here we go. Let's go to slide 2. So you're seeing who the coalition is. Prices for healthcare have increased much faster than inflation. You heard Senator Lang talk about it. And this slide is just a testament to in the last 20 years, the cost of hospital services has increased 200%, when overall inflation in that time has increased 54.6%. To compare how that has hit all of us, college tuition in that time has increased 170%. Other medical services have increased 120%. Housing has increased 60%. So while the average overall inflation rate has gone up 54.6%, hospitals are at 200%. Next slide. Just to further demonstrate how that feels to us, if the same thing happened in the supermarket, we'd now be paying over the last 20 years, we'd be paying $57 for a set of oranges. Eggs, a carton of eggs would cost us $65, and a gallon of milk would cost us $160. So this is the trend that we're trying to interrupt. And next slide. There's really three kinds of consolidation going on. One is horizontal mergers, which I'm going to talk about now. Another is vertical mergers, and then the private equity issues. So basically, studies show that healthcare consolidation results in higher prices and without improving quality. And that's happening when hospitals buy other hospitals or doctor groups buy other doctor groups. That's what horizontal mergers are. You see an increase in prices. You see an increase in premiums. You see reduced wage growth for the workforce. And you don't see improvement in quality in general. It seems like it's not an indicator of increased quality. Next. So that's horizontal, they buy each other. Vertical mergers, it's where one group buys a lower group in the healthcare tier, like a hospital buys a doctor group. And we have some state laws about that in this state, but we also have some cases where doctor groups are being bought by hospital groups. That results in higher clinical prices. It also results in higher hospital prices. And again, little to no quality improvement. Specific ways that this happens is when a hospital buys a physician group, and it can then start charging a facility fee for a physician group. So you're paying an additional fee for no additional care because of who owns the facility now, when a hospital group buys a physician group. So that's one really clear way that prices are increasing. Next. Well done. So in the last 5 years, there's been over $10 billion in private equity investment that's gone into healthcare nationally. And as I said, we're seeing that in Nevada now, and we are trying to get our arms around it. So state and federal authorities exist to protect this competition. You can kind of see the AG bill that moved through session this time that you guys probably heard. There's an AG bill that tried to think about how to better look at these mergers, but these mergers fly too far below the radar screen for the AGs to be involved in them. And they're not about, the AG only gets involved when a merger is so large that it really changes the entire market all at once. And what we're seeing is incremental change that you don't see at all. You just feel it and you pay for it. So it can take years and tremendous resources to do this through the courts. And so what we're trying to do is increase our opportunity to interrupt the price trends that are going on with eliminating some of the non-competitive languages in our contracts, but also create enough transparency to see what's going on, even if we can't interrupt it through some transparency laws that we don't have right now. And that's our goals. So I'd like to pass it on to Maya Holmes from Culinary Health Fund, who's going to talk about the bill itself. Thank you.
For the record, I am Maya Holmes with the Culinary Health Fund. SB 329 will ensure that Nevada has accessible data on what is happening in our healthcare markets. Collecting basic information on healthcare mergers and acquisitions is critical for the state, policymakers, patients, payers, employers, and other stakeholders to understand consolidation in our healthcare markets and guide decisions that protect competition and patient choice. SB 329 will also prohibit anti-competitive contracting practices that hospitals and healthcare providers with market dominance can demand because payers need to have them in their networks. SB 329 will address market players using their market power to drive up prices and thwart competition based on price and quality. Recent settlements in two major antitrust lawsuits, one in California and another in North Carolina, ended many types of anti-competitive contracting, ended many types of contracting, anti-competitive contracting practices through those settlement agreements. However, the settlements do not set legal precedent and only apply to the health systems involved in the lawsuits. Anti-competitive contracting practices like all or nothing and anti-steering and anti-tiering provisions prevent health plans from directing or incentivizing or communicating with patients to move them towards lower cost, higher quality care. These provisions also prevent other hospitals from benefiting if they offer better deals or higher quality. They also stop patients and health plans from shopping for and getting the best deal that is appropriate for themselves. Specifically, SB 329 has two primary provisions. The first provision provides important transparency into consolidation of our healthcare markets. The bill will require reporting on healthcare deals in Nevada involving hospitals and physician groups within 60 days after they have occurred. And this is just basic summary information that will be reported, and it's listed out in the bill. But we do not expect this to add any significant administrative burden. This should all be easy and accessible information. SB 329 also requires DHHS to post the information contained in the notices on an internet website maintained by the department. Connecticut already does this and has done so for several years. DHHS will also prepare an annual report regarding market transactions and concentration in healthcare based on the notices and post the report on an internet website maintained by the department. The bill's other major provision will make specific anti-competitive contract provisions unfair trade practices. Prohibited provisions will be void and severable. The prohibitions will also only apply to new, not existing contracts, so it will not disrupt existing agreements. The specific contract provisions between hospitals, health systems, providers, and health plans that will be prohibited as unfair trade practices are anti-tiering and anti-steering provisions. The antitrust language we want this bill to end prohibits flexibility to promote programs that help patients find the lowest cost and highest quality care in the network based on patient choice and priority. Our plans want to keep all facilities contracted, but be able to have a lower copay for places with a higher quality program like knee surgery or prenatal care, which costs the patient and the plan less money. That is what steering does in plan design. Instead of forcing us to treat every hospital the same, which is what the monopoly-like language does, we now have to contract with all hospitals the same way, regardless of the rates they are charging or their quality. This prevents plans from educating, directing, or incentivizing patients to utilize lower cost, higher quality care. The other provisions that would be prohibited are all or nothing contracting. These clauses are when a hospital system refuses to contract with our plan unless all hospitals in their system are included in the contract. We usually want this too, so patients are not confused about where to go in a network. But when a hospital system controls the majority of beds in a community and they force this provision into the contract, we can't negotiate on an even playing field. If we need our members to have access to hospitals near them, we have to take all the hospitals the company controls, even if one has quality problems, even if it drives up healthcare costs or is a lower quality facility. Forcing plans to include higher cost, lower quality facilities and providers is the opposite of value-based care and undermines efforts for truly successful coordinated care. SB 329's prohibitions on anti-competitive contracting provisions like anti-tiering and anti-steering and all or nothing will not limit the ability of a hospital, providers, or plans to negotiate networks or what those networks will look like. It will simply affect language that restricts the ability of plans to communicate with, educate, direct, or incentivize their members to utilize lower cost, higher quality care, which benefits the patients and the plans. Now I'd like to turn the presentation over to Katie Goodixon to discuss what is happening in other states. Thank you so much.
Thanks, Maya. Sorry, I just need to share my screen. So for the record, my name is Catherine Goodixon, and I work at the Source on Healthcare Price and Competition. And I just need to say that I'm speaking only for myself today, and anything I say doesn't represent the views of University of California, Hastings, the Source on Healthcare Price and Competition, or their funders. In our research, we look at what other states are doing, and as Maya described, there were two big lawsuits alleging anti-competitive use of anti-tiering or anti-steering clauses. And after those lawsuits were settled, after great time and expense, many states have sort of taken up the mantle and asked what they could do to prevent some of this legislation as well. As you can see from my map, Massachusetts is the only state that's actually banned these provisions already in statute, and their law passed more than 2 decades ago. At the federal level, Congress considered banning these provisions in a couple of bills last year, and one in the Lower Healthcare Costs Act of 2019 actually came close to passing. And the CBO issued a report about that bill and found that nationwide, if there was a ban on anti-tiering, anti-steering clauses nationwide, the country would save over $1 billion over 10 years. So I think the interest in these clauses is really starting to pick up, partly because of those lawsuits and the congressional bills. And so far this session, 7 states have introduced bills to prohibit anti-tiering or anti-steering clauses. Similarly, for all or nothing clauses, the other clause that SB 329 would prohibit. Massachusetts is the only state that has a restriction, and frankly, it's a pretty narrow restriction. It only applies in narrow network or tiered network plans. But again, this clause was considered in that Lower Healthcare Costs Act in Congress, and so far this year, 6 states are considering banning these provisions. So in summary, there are 8 states that are considering bills to restrict anti-competitive practices, and it seems to be a real subject of growing interest. So I helped write some model legislation for the National Academy of State Health Policy, NASHP, because they were getting interest from states to ban the use of these clauses in most insurance contracts. And so just to summarize, there's growing interest in the ways that state laws can support antitrust enforcement by banning specific provisions that have been used to drive up prices by dominant health firms. And I am happy to take questions.
And are you all ready for questions at this time? Okay, wonderful. If we can go to, I'll just start down the row here. If I can start with Assemblyman Hafen.
Thank you, Madam Chair. I have a number of questions, but I just kind of like to start with trying to get a better understanding of what we're doing here. Under the current law, a hospital and the doctor groups are covered under one plan. It's kind of one negotiation, and what we're trying to do is split that up. I think the term used was monopoly. Is that correct? And then I do have a follow-up.
For the record, Chelsea Capurro, Bobette, looks like maybe you want to take that one.
Yes, I can try. Thank you, Madam Chair, through you to Assemblyman Hafen. I think that.
Can I make sure you put your name on the record, Ms. Bond?
Oh, sorry.
And feel free to go directly to the member.
Okay, thank you, Chair. I think there's 2 things going on. One thing that we're trying to do in this legislation is start tracking transactions where a group is buying a group. That's one thing. The second thing we're trying to do is we have contracts where this monopoly language is in the contracts. And it's not a monopoly between a hospital and a doctor right now so much that we're talking about today, but it is a hospital system that has a monopoly number, a percent of beds that is created a monopoly in the area. They have over half the beds, hospital beds. And so they insert language into the contract that requires you to not do any of these other creative things about working with a physician group that is, not their physician group, or a hospital that is not in their system that has a great women's health program. They call that anti-steering, that when we tell our patients that there's a better place to go, they call that steering the patient. And so our contracts with one hospital system don't allow that. And it then, because it doesn't allow it in one system, it's impacting all the systems because we can't do it anywhere. We're not the only ones that face this issue, but we're the ones bringing it to the legislature today. Was that helpful?
A follow-up, Madam Chair.
Go ahead.
I fully understand that the way the insurance and the hospital systems work is very, very confusing. Myself, I struggle with trying to figure out where I can go and where I can't go. My concern here, though, is right now, under the current system, I have a fairly comfortable way of navigating when I go to the hospital, that some of these things are going to be covered. And it appears under this bill, the intent is to actually break that up. So if I end up at a hospital that's under my plan, the radiologist group may or may not be covered under this plan, and that just draws some very serious concerns to me, and hopefully you could address why that's a benefit. I look at a one-stop shop as a much more benefit to the patient, including myself, than having to go to a hospital, check in, and then be sent to a radiologist group, clear across town, or in my case, possibly another town.
I'm Babette Bond for the record. Assemblyman Haven, I don't think that is not where this bill is intended to go. Where this bill is intending to go is if you're in negotiations with the hospital and the quality scores or the price of that hospital is higher in price and lower in quality than other hospitals, then you want to be able to negotiate a rate with that hospital that takes that into account, where you can negotiate a different rate for one hospital than another. That's one thing that we would like to do in our contracts. So that's why we talk about it in monopoly terms. The language that's being inserted into contracts does not let us do that. So we're not trying to eliminate that hospital from the contract. We're trying to be able to steer people to it in different ways. So if it's the most expensive contract we have, then we would tell our patients, look, you can go to these other 3 places for less money. This is your cost share. It's lower somewhere else, or it's better quality. Or we'd be able to work with one hospital on their special, women's health program. That's a real example we're dealing with right now. So it's not about breaking up the hospital and the doctors at all. It's more that we want to eliminate the language that doesn't allow us to send a patient to one hospital with their radiology group at a lower cost than the other hospital, because that's called steering. We're not trying to break up the radiologist from the hospital at all.
And for the record, Chelsea Capurro, if I can just jump in here too, this bill doesn't do anything to address our current contracts. This is only for things going forward. And then I would also point out, the biggest thing is that we just want to be able to communicate to our members what options are out there and what healthcare is out there and what the costs are and what the quality is. So this isn't going to change us saying you can't go to this radiologist, you have to go here. It's saying you can have all these choices. If you go to radiologist A, it's going to cost you this. If you go to B, it may cost you this. Some of our contracts restrict us from even giving information about costs to what different hospitals may cost if we go there, or if a member says, how much will this knee surgery cost us? We struggle with being able to direct them and say, if you want to go to hospital A versus hospital B, here's what that price difference is going to be.
So, and Babette Bond for the record, just to follow up, that is, I think it's important to say, we think that fixing this will impact the networks really much better, because right now our only alternative is to eliminate this hospital system from our network, and we don't want to do that. We want people to have choice, but we want the members to drive that choice. We want them to be informed about which hospital they want to go to. So if you want to go to the Great Women's Hospital because it's got a high quality care around deliveries, then we want to be able to say that information. But if you don't, if you want to go to whatever hospital your favorite obstetrician is practicing at, then you should be able to do it. But this is going to be the price difference. We can't do that right now.
And go ahead and follow up. And I would just ask the presenters if you could just have one person respond to the question. I know sometimes you may need additional people, but I don't want to. Yeah. We have quite a few people that want to ask questions, so I want to make sure we have the opportunity to do so. Go ahead with your follow-up.
Thank you, Madam Chair. And I'm sorry, I'm not following, maybe because I'm not an insurance provider or a doctor, but first I hear that we want to split up the monopolies, and now we're talking about we as the insurance provider want to steer patients to one hospital or the other. And so I'm really confused now what it is that we're actually trying to do here. Are we trying to allow the insurance companies to steer to certain hospitals and away from other hospitals, or are we trying to break up a quote unquote monopoly and get rid of the one-stop shop?
For the record, Chelsea Capurro, this is not about breaking up monopolies. This is about having the opportunity and the ability to provide our members, the patients, your constituents, with information about their health care. And Chelsea Capurro, for the record, if it's helpful, I can follow up with you offline as well. As I know the chair said there might be some more questions.
I just keep getting conflicting answers, and so I'm just trying to figure out where we're actually going with this. So thank you for the answer, and thank you, Madam Chair, for indulging me.
If we can go next to Assemblywoman Summers Armstrong.
Thank you, Madam Chair. Thank you, Ms. Capurro and the Senator for bringing this bill. So let me just follow up with Assemblyman Haven. Okay. It's been a long day. All right. So I had a high-risk pregnancy many years ago, and my OBGYN really wanted me to go to a particular hospital where I could receive good care for the delivery of that child. And that child was not in, that hospital was not in my group plan. What are you saying that this would allow me or me to ask my insurance people, hey, I want to go to this other hospital, and I would be able to go there? Or would allow you as the group to have that hospital as options because you look at your body of insureds and see that you have older patients and that there may be a need for a place for women to go for high-risk pregnancies, and maybe the group that you have a contract with doesn't have the facility in there, and you could add that group, another hospital, into the options for that group, is what I'm trying. I hope that made sense.
For the record, Chelsea Capurro, maybe Stacy or Bobette, you want to handle this one. Sorry, I don't know if my mic was on Stacy or Bobette. Stacy, maybe you want to grab this one.
Okay, sorry, having a little issue here. I don't know.
Can I get you to state your name for the record?
Sorry, Stacy Sasso for the record. Bobette, I think you might actually be better to answer this.
Okay, Madam Chair. Sorry, we're like too many speakers. Assemblywoman, I think it's the second, what you said. It would allow the insurance plan flexibility to create opportunities for you to go to the hospital. You might pay a different amount for that though, and that's called steering. Alternatively, the insurance plan would not put that hospital in network, and then you wouldn't have the opportunity to go there at all. So it's a way, our perception of this is it's a way to keep all the hospitals contracted, but have options that are more or less expensive depending on the cost and the quality of that hospital. And that would be a decision that you could make with your doctor. It increases the decision making you can make with your doctor.
Thank you.
Next, we can go to Assemblywoman Gorlow.
Thank you, Chair. Throughout the presentation, you've been mentioning about these quality scores. Could you elaborate a little bit more on how the quality scores are determined and who determines the scores?
Bobbitt Bond for the record. We follow at the Health Services Coalition a series of scores. Some of them are built into our contracts. For example, what the rate of sepsis is that a hospital would have, or how many readmissions the hospital has. Those are numbers that we collect, but it's also public record. There are public databases that are created. CMS, which manages Medicare and Medicaid, they have a set of scores that they use to compare every hospital in the country to each other. There's a company called Leapfrog that has a national set of scores where they're comparing quality. And there's other tools out there too that are used, but those are the two biggest ones. Those are the two most commonly used ones. So they allow you to see how hospitals are doing across certain factors, and then you can bring that into the way that you want to contract and the way that you want to educate your membership.
And follow-up, Chair? And how would that work with, say, a hospital that has multiple departments where maybe their OB department's really good, but their radiology department might not be so good? So how would that work with, in that case?
Bobbitt Bond for the record. That's exactly what we're trying to get to. We would like, if their OB department's really great, to be able to sort of highlight that in the way that we structure the plans. And every plan is going to structure the way it works best for their members. There's no like one structure, but if everyone's contracted and we can tier or steer, we could design a plan that says, okay, this hospital has the best OB scores, so we're going to have the lowest rates to go to this hospital because they have the best outcomes, versus we're not going to kind of tell you that about the radiology program. We're going to tell you, what we know about the radiology program for those scores that we can get. So it's to help us develop some consumer tools and some patient choice while keeping all the hospitals contracted. What we have to do that is remove this language in the contract that doesn't allow us to do it.
Okay, thank you. And I'd like to follow up a little bit later on offline about some more questions because I'm afraid it might take a little while to get some more clarification. So thank you.
Assemblyman Matthews, I believe you're up next.
Thank you, Chair, and thank you, Senator, and all the presenters. A question on the economics of this regarding Section 20.9C. My understanding is that hospital firms are able to provide contractually lower prices when they are assured of higher volumes. And so assuming that's the case, when you have the forced fragmentation under this, which I think is what Assemblyman Hafen was getting at, how would this lead to anything but higher prices? It would just seem to me that subsection C and D of Section 20.9, I believe it is, would just work together to make healthcare more complex and more expensive for patients. Thank you.
I guess Bobbitt Bond for the record. We negotiate our contracts in cycles of 3 to 5 years, and our rates and our programs are set on what the quality scores are and what we've already been paying and what the patient experience is and what the outcomes are. I think C and D What would actually change is instead of us having to just pay a blanket rate for contracts, we would be having conversation with the hospital about, we don't really see the quality in this hospital for this procedure. We'd like to talk about different rates. And I think what will happen is it's possible, as you're suggesting, that the rate in one hospital would go up for us, not for members, but for us to pay that rate. But in others, it would go down. And being able to steer people to the best care for that procedure they need will help us manage costs and outcomes. So I think we do get value out of a rate of having all the hospitals contracted, but we have no flexibility in this tiering and steering language. So if we remove that tiering and steering language, then everything else is handled in the contract. And if the hospitals want to charge us more because we now are able to steer our patients, that's a negotiation we're going to have with the hospitals instead of just a prohibition.
Okay, thank you. Thank you, Madam Chair.
Next, I have Assemblywoman Titus.
Thank you, Madam Chair. Thank you, Senator Lang, for bringing the bill forward, because frankly, I think your concerns about healthcare costs are definitely accurate as far as the healthcare costs going up and what are we doing to lower healthcare costs. And having had to give up private practice after 15 years in private practice and go work for our local hospital because I couldn't afford to be a private practitioner any longer, I'm acutely aware of the problems in healthcare and cost. And I have concerns about what this bill does, however, and perhaps the opposite of what you're trying to solve. One of the things I have a question on is that as a insurance provider or a payer, as you are the culinary union, I see you being almost guilty of the very thing you're trying to then have, say, physicians are or providers are, because do your culinary union members have options of another insurance plan other than what you give them?
No, Bobbitt Bond, for the record, our insurance plan gives them comprehensive coverage and a large network and all the hospitals contracted. And that is just us. Stacy Sasso, who's here from the coalition, can talk about the other 24 plans that are in the coalition. Okay. They're all different.
All right, thank you for that. The next thing is when you make a contract, or when you have a contract as a provider, I know many years ago there was something called the Stark laws that came out, and there was already federal legislation that was put together to prevent some things where a provider would own in the interest of lowering cost. The federal government recognized that providers shouldn't own the x-ray equipment that they then refer their patients to, and there's been national concerns about that indeed increasing the cost of healthcare. So there's been regulations already to help lower that. And for me, when I see the culinary union do, or your insurance plan do, as other insurance plans do, is you negotiate with hospitals certain rates. And one of the issues I've had concerns, it's not actually about cost reimbursement. So you're wanting to know what the true cost is of doing business, I think would be ideal. And if you paid and reimbursed the providers, the hospitals, all providers, their costs, then I think you might be surprised that healthcare rates would come down by nature of the beast, because they're not charging the extra fees for those that aren't getting reimbursed at all, or the care that they give. So I think the concept and the solution would be, if we truly did know and ask all across the board, what's the actual cost of doing business? Because I think that for me would be the solution to the cost reimbursements. And I think, I'm not sure you're asking the providers the right questions as opposed to preventing them from joining, because I had to join something else because I couldn't stay in business. And to go after the providers and even making a felony if they, on 20.9, it becomes a felony if we're trying to stay alive, because frankly, most of these mergers are happening not because they want to make more money, but frankly, they want to stay in business. And they can't survive in a small group of 5 because they don't get reimbursed enough. So I'd support efforts along your line to, let's find out what the true cost of doing business is, and then make sure that you cover the cost of doing business. And then, there's not the winners and losers that I see right now, that you then are in the driver's seat of negotiating these contracts. And for me, this does absolutely the opposite of the problem I'm hearing you're trying to solve, which is allow your members to know where they could go and what those costs really generally are, and then direct them that if you go to this hospital, this cost is this. And I do that now in healthcare, and I have my patients say, okay, call the radiology department, find out what that's going to cost you to have your CAT scan if I'm paying cash payer, and negotiate the cost. I think that truly is the solution, and I'm very concerned that this bill does absolutely the opposite of what you're trying to do. I guess that was more of a statement than a question. Thank you, Madam Chair.
Madam Chair, for the record, Bobette Bond, I would just like to clarify, we agree with you that more transparency is needed. We spend a lot of time as a coalition on healthcare transparency. Completely agree with you, Dr. Titus. I think the issue you're raising about on 20.9, the felony, is not about the merger. It makes it prohibitive to have these language in the contract that doesn't allow us to tier and steer. That's what's being prohibited, that language no longer can be used in contracts to prohibit us from doing the tiering that we're talking about, or the steering. That's all we're trying to stop. And the reason it's a felony is that's the way the state law is written about what happens in a situation where you're dealing with this antitrust scenario.
Do you have a follow-up?
Well, I have a lot, but I'm thank you, Madam Chair, for the questions, and I appreciate everyone's time.
Thank you. Next, we'll go to Assemblywoman Peters.
Thank you, Chair. And if you would indulge me, I have questions on both Section 1 of the bill and Section 20.9. If I may, I will start with my clarifying legal questions in Section 1. There were a couple of concerns about the breadth of which this section would cover mergers and acquisitions. As we know, not every hospital or provider network in this state is isolated to the state of Nevada. So in this language, would this pertain to only mergers and acquisitions in the state of Nevada? And then my second question, which I think can be answered by legal at the same time, is we talk about other affiliations between physician group practices. We talk about physician group practices, hospitals. Does this pertain to those like situations in which we have an insurance company that is a part of a healthcare provider / hospital entity who may be acquiring new facilities or new partners under their kind of umbrella?
Bobette Bond, for the record, Assemblywoman Peters, are you directing that to me, or are you directing that to legal? Because I know what the intent of the bill is. It would probably, the intent of the bill is that your second question, yes, it would capture those. And your first question, would this cross state lines, would be no, because it's a state statute. So, HCA Hospital, they have 3 hospitals in Las Vegas. This would only impact them in Las Vegas. It wouldn't impact them in Arizona.
Thank you. I would, sorry, very close to the mic. I would ask legal to weigh in on what this language actually does say and ensure that that's being covered under this language. Carly, I believe you're muted.
I'm so sorry. Can you hear me now?
Yes, Ms. O'Krent. Sorry, I used a first name. I apologize.
Oh, no problem. I'll take the questions one at a time, starting with whether or not this applies to providers that have groups that are in other states. So it is possible that this bill would apply to providers that had groups in other states if those groups merged with groups in this state. So the committee, if it so chose, could amend the bill to make the bill only applicable to provider groups in this state, I think the committee would need to specify exactly how that would look. And then with regards to the other question, Section 1 of the bill does not apply to insurers. So I'm not sure if that addresses your two concerns, but that's how the bill works as it's currently drafted.
Thank you. Yeah, my question is related to groups such as Optum, who have like provider umbrellas that they also have under their insurance network. And as they purchase those providers under their umbrella, would that scenario be captured under the data collection described in Section 1, or would it be excluded because Optum is an insurance company?
As it's currently drafted, it would be excluded from Section 1 because Optum is an insurance company.
Thank you for that clarification. And if I may, Chair, I have additional questions related to Section 20.9. I'm taking that as a yes, go ahead. Okay, so intent of this language. Now, I'm not familiar with contract language in your negotiated contracts with healthcare providers. And as I read some of this, I got concerned about situations in which you would want to have those hospitals and their the attached like groups in the same coverage, right? And if that was your only option, which is one of the scenarios we have in Northern Nevada, we have 2 major hospital groups, and I often patients prefer to be using those network groups because they know that they're covered under their insurance, or they're connected through either how they share data or how they bill or whatever. So my question is, when you're talking about the language that restricts these different points, these subsections in Section 20.9 sub 1, what does that language look like? Would it be if I saw a contract that said we are contracting with this group and its subgroups? Would that qualify as this requires the third party to place all providers of healthcare affiliated with a business entity in the same tier? Or is there separate language in the contract that says, upon contracting, we limit you to only our groups and under our network umbrella, and they are listed below?
Babette Bond for the record. Thank you, Assemblywoman Peters. I'm trying to make sure I understand your question. I think what we would do is your second example, but I want to make sure I understand what you're saying. What we would do in the contract is, actually, I probably just need you to explain it again.
No, that's fine. I guess what I'm looking for is, can you give us an example of the language in your contracts that restricts you from steering and tiering that you're trying to eliminate with this language?
Absolutely. Thank you. For the record, Babette Bond. We actually have language in some of our contracts that we have been unable to remove through contract negotiations that says you are not allowed to tier or steer in any way. And when we say what we want to do is start a program where we can provide a special benefit inside our fund or inside our coalition to allow people to, for example, go to a women's health program that's only at one hospital, and we want to make a separate price for that, and we want to have our maternity patients go there. That's called tiering. That's called steering. We're not allowed right now to do it because of that one sentence in our contract that prohibits tiering and steering. And that's all we're trying to do, is remove that one sentence and then allow the rest of the contract to flow as a contract would.
So I guess my follow-up question is, in this bill, why wasn't just a line item that says the contracts cannot include clauses that prohibit steering and tiering, and instead we use these descriptions of restricting or requiring or prohibiting?
Babette Bond for the record. I think the language is just nationally established language, and it was suggested by our consultant to make sure that we captured the issues that steering and tearing are. I think it just became a more specific explanation, but the intent is what you just said. That's where you go. That's where you get.
Okay, because I don't want to have a scenario come up where an insurance provider has made has a contract with a health provider that inadvertently puts them in a situation where they have restricted their network to only that provider umbrella, right? And then put them in this category. And so that's my concern in wanting to get on the record that the intent is not to capture those scenarios, that in that good faith negotiation, those situations can happen. But what this is really trying to get at is that anti-steering, anti-tiering clause that prohibits you from doing those things within your member groups. And then my third question, and I apologize, Chair, if I can go on to one more question. My other question had to do with how this language that you're presenting here in section 20.9 compares to the language that was referenced in Maryland.
Sorry, this is Katie Goodixon for the record. I think you meant Massachusetts.
I wrote Maryland, but yes, Massachusetts.
The language is quite similar. I think the anti-tiering, anti-steering is the same. I would have to go back and read that. But I can get the statute citation or something for the committee. And it is very similar to Massachusetts on the anti-tiering, anti-steering portion of the bill, that one clause.
Thank you very much. If you would follow up with the committee with that information, that would be helpful.
Next, we have a question from Assemblywoman Krasner.
My question was already asked. Thank you.
It looks like next I have Assemblywoman Benitez Thompson.
Thank you so much. And so what I was hoping to do, and I kind of a piece of it with, I think maybe A was talked on, but in 20.91, there's 5 things, the 5 shall nots, the A, B, C, D, and E. And so because I'm sure, well, maybe we have one here, Assemblyman Oren Lichter, who might have sat around and read one of these contracts before. I can imagine that most of us, although if we work in healthcare or might see things kind of on the ward level or the floor level, if you will, of things, what gets negotiated and what gets contracted are rarely, I think, kind of seen or read by people, right? Some of these things are, I imagine, considered proprietary. So it's not something where we have a bunch of these that we can laying around that we can read. So I thought what might be helpful is really clearly on the A, B, C, and D on these shall nots. And we've been kind of focusing on A, on the steering, right, the incentives. But if you could do an example of what the shall not is, and then if enacted, what the will allow is, right? Just so that we can hold an example of each one of these things in our head. I've heard a reference to a women's clinic, but I don't think I have it quite contextually. And so if we could do that, I think that might be helpful to kind of give us, and also good for the legislative record on, kind of concretely where we are in the status quo on A through E, and then where the bill will lead us with A through E. Like, for example, on A, I'm like, incentives. Well, I don't know, do we have incentives defined somewhere? I guess, when we think of incentives, is it just like a bonus in an HSA? Is it a lollipop? You know what I mean? So I guess that's what I'm looking for, is take it down to the level where a little bit more pedestrian and outside of contract law. An example for A through E.
All right, I'm going to try to do this unless somebody else on the phone can do it faster than me, somebody else on the line. So either Katie or either Stacy, who deals with our contracts all the time, is one of you more comfortable just going through this? Can our consultant do it? That would be faster, I think, than me.
I'm absolutely fine with
Babette,
you
I
doing
think-
Miss Bond. I think that's fine.
Go ahead, Ms. Bond, unless you have another
We're gonna use
individual
me,
who
okay.
wants to.
Okay, they might have to help me a little bit with this. So restricts a third party, so from offering incentives, we want to remove that so that we can offer incentives for a covered person to use a specific provider, meaning they could have a lower copay. That would be an incentive. They have a lower copay to go to a specific provider. Right now, that's prohibited. That would be allowed under number A. B, restricts the third party from assigning providers and healthcare into tiers. Right now, we have to have all of our hospitals have completely equal communication materials, copays, deductibles, listing in our director. Everything has to be exactly the same amongst our providers. If we had tiers, we could say, okay, for knee surgery at this hospital, it's going to cost, and we do this in our benefit design and our contract, it's going to cost you, the patient, $250 to go to hospital A. But because of the quality scores and the cost to us, it's going to cost you $125 to do it here. That's tiering. That's item 2. So 3 requires the third party to place all providers and affiliate with the business entity in the same tier. With a business entity in the same tier. Healthcare affiliated. I need help with that one.
So I'll jump in. This is Catherine Gregson for the record. So this would be if a health system said you need to put all of our clinics in the same tier at the same cost sharing. So if you want to put our women's health at the lowest cost pay, you have to also put our radiology group and our MRI machines at that same group. So it just allows, it prohibits a health system from saying everybody has to be at the same tier and gives the insurer or the payer the flexibility there. I think I'll just keep going, Babette. The 4th one is to require a third party to contract with a business entity affiliated with the provider as a condition of entering that contract. So for example, if an insurer wanted to contract with only the main hospital and not all of their affiliated clinics that they felt were of lower quality, this would prevent the health system from only offering a contract that was for all of those systems. So the insurer has to be given the right to contract with just one of those entities. And then the 3rd one is prohibits the third party from contracting with a provider of healthcare that is not a party to the contract or a third party for entering into such contract. That one is more about exclusive contracting. That one is where the provider prohibits the third party from contracting with somebody else. So if you want to contract it with us, we're the only ones that can provide that service.
Thank you so much. That helps. And my apologies, because pieces of the audio were not great. And then I have not great ears, and my hearing aid broke, and I can't get a new one until next week. So I just want to clarify. I don't have them in, and life is hard. So when we were talking, I think it was on the B and then the C, where we were talking, these are the 2 pieces talking about a tier, and one is tier restrictions, and then the other one looks like kind of tier clumping, right? And so on those, I think I heard the example of it would be the lower cost, a lower copay for the insured person to be able to say, this hospital is going to be at $250 if you go to it, but if you go to this hospital, it's $125. And so that's where you would see that tiering. So it's the price tiering. It's not necessarily a categorical tiering. Okay. And then that's also the same then for C. It'd be the categorical tiering or not categorical, but pricings in different tiers versus I think we were talking about a women's clinic and an MRI group, all groups having to be like one cost to the person, to the insuree, to the insured person.
Catherine, you're going to have to help because I'm sorry, for the record, Bobette Bond. I want to make sure that you're responding to exactly what she's saying in the last part of her sentence. I'm not sure that's what that is.
Oh, I can.
Right, so I
want to make sure we get this right.
Okay, so this is Catherine Goodixon for the record. On part C, it would depend on how the insurer has structured those tiers. So typically they are different cost, either copays or cost sharing, but it actually would be up to the insurer to determine what it would mean to be in tier 1 versus tier 2. But the language there is just prohibiting the health system from requiring everything to be in the same tier with that same cost sharing or copay or however those tiers have been structured. And then the restriction on B is just a restriction to even putting them in tiers. So some of these contracts do say, if you want to contract with us, you can't have a tiered network. And B just requires the health system to allow the insurer or payer to have a tiered network to begin with.
And this might sound, I guess, kind of obvious, but it sounds like, is this the normal course of business then? Right? The way that the trends of the contracts and the way that the contracts are coming out are across the board. No matter where you go to contract, you're going to run into kind of these tier restrictions, and the networking, contracting to contract with the D, right? Contracting with affiliates. Like if you're going to contract with me, you got to have the whole kit and caboodle kind of thing. So it's almost, I guess, am I correct in assuming that those types of pieces are probably boilerplate for most insurers when they're negotiating contracts with hospitals? Or is it a uniquely Western trend? Is it a uniquely Nevada trend? Is it?
Bobette Bond for the record, I don't know how unique it is, and we don't do it now. We don't do it because if it's held up in one contract, it would be held up. We can't do any tiering or steering. So I don't know how common that tiering is or the steering in plans. We just don't do it, and the coalition doesn't do it. And what we'd like is to, in order to make sure we keep all of our hospitals contracted, the ability to do it when we feel like we should be able to do it. I don't know how widespread it is, though. And it would all be negotiated in the contract. So we're just removing the language that prohibits us from doing it and then negotiating it in the contract.
So it sounds like that. Sounds like deaggregating and then negotiating all of these pieces out. And then we're in chapter 5.9a, right? So we're in the chapter on unfair trade practices and everything like that. And I guess as I read the chapter, and this is, general law, applicable law, there's nothing really targeted towards healthcare in here right now. But I understand that the chapter has been applied kind of towards healthcare. So we have some case law out there on some of these things. I would imagine like the non-competes, although I think that's what D would be interpreted as, the contract with our affiliates, but I don't see anything in here. I think that was more a piece of Assemblywoman Peters' questions, but I think that's already inherently illegal, right? The exclusivity, I mean contractor exclusivity. So if you contract with us, you can't contract with anyone else for provider groups. But I guess, am I correct in that assumption as well, that 598 gets used as a tool in healthcare, but I would guess from these shall nots, not as frequently as we might think? Or it's an arduous process, or it feels like when it comes specifically to conversations about these contracts, the level is different than it might be for investigating other types of acquisitions and such.
Bobette Bond for the record, I think we might need Catherine again on this, but what I'm understanding from what you're saying is the unfair trade practice language, and that language was just referenced in statute because we want it to be unfair, and we don't have any other hooks on this. We don't have any other way to prohibit. We don't have a fine. We don't have a way to, otherwise penalize a contract that has this in it. I think what's going to happen is we just won't have this language anymore. That section will be out of our contracts because no one wants to commit an unfair trade practice. But the rest of the language in here that's referencing this is just related to the state statute now. It's not specific to this bill.
So to just jump in, this is Katie Goodixon for the record. Other states, so California and North Carolina, California brought it under state antitrust law, their lawsuit against Sutter against state antitrust law. So at a certain level, this does rise to an antitrust violation that could be brought under state antitrust law. But this basically eliminates the need for proving kind of the standards and the geographic markets, et cetera, that are needed for an antitrust lawsuit. The Sutter case took a decade to reach settlement. So that's the reason for this law.
Do we have any other questions from members at this time? Seeing none, I will begin testimony in support of Senate Bill 329. Is there anyone in the room to offer testimony in support? If you are, I'd ask you to come to the table. Please state your name for the record and begin your 2 minutes.
Thank you, Madam Chair, members of the committee. For the record, Rusty McAllister with the Nevada State AFL-CIO. I had prepared remarks to give today, and after listening to some of the comments, it brought me back. This gray hair here means I'm old and I've been here a long time. But there was my first session of lobbying was in 1999. I was just a dumb firefighter here trying to hold our own. I was also the chairman of a health insurance trust fund. And I got asked to attend a subcommittee hearing one day, one evening, and the discussion was the clinical psychologists were trying to pass statute that made it so that the marriage and family counselors couldn't see certain patients. They had to go to a doctor first and not to the licensed counselors. And I listened to the whole hearing. The chairman of the committee said, "Hey, you've been here all the time. You want to come on up and say anything?" I said, "Yeah, I do." And I said, "I know this is unusual. Can I ask a question of them?" And she said, "Sure." So I said, "So if somebody came to you and they had a problem with a marriage problem or family counseling problem, would you refer them to them?" And they said, "No, why would we? We're licensed to do that. We wouldn't do that." I said, "So you're basically cutting them out of the business." I said, "All I know is this. If it costs $200 an hour to go see that person or $50 an hour to go see that person," I said, "our members, if they can't go there, they won't go there. They won't go see that person. And if they don't get the mental health care that they need, bad things happen. The more things change, the more they stay the same." That was in 1999. We're battling every day as the chairman of the Health Trust, and I watch these people that run these health programs now. I had only 3,500 members in our trust fund. And as Dr. Titus said, constantly trying to keep your head above water, that's what health trusts are trying to do too. And anything we can do to limit the ability of hospitals or networks or providers to increase our costs, there's only so much money. You can't just go get more money and give it to them. So the bottom line is we're constantly trying whatever methods, techniques we can to limit our liability. We believe that Senate Bill 329 allows patients and health plans to shop for and get the best options available to them, both in quality and cost. And so for those reasons, Madam Chair, we are in support of this. Our 150,000 members and their families need techniques just like these to try and limit the costs that are going out of their pocket every day. And so for that, Madam Chair, we're in support of this. Thank you very much.
Thank you for your testimony. Do we have anyone else in the room to testify in support of Senate Bill 329? Seeing none, is there anyone additional on the Zoom that is on the Zoom? I don't believe there is to testify in support. So at this time, we will go to the telephone lines. Broadcast services, can we begin testimony in support?
To testify in support, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 741. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair and members of the committee. My name is Paul Catha, that's spelled C-A-T-H-A, and I represent the Culinary Union. The Culinary Union supports SB 329 because healthcare affordability, quality, and access are critical concerns for Culinary Union members. Consolidation in the healthcare industry drives up prices, but not the quality of our healthcare. SB 329 will take important steps to understand how consolidation impacts our healthcare markets. In addition, SB 329 will stop anti-competitive contracting practices that prevent patients, employers, and plans from shopping for and getting the best deal. The Culinary Union urges the Nevada Legislature to support and pass SB 329. Thank you.
Caller with the last 3 digits, 658. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last 3 digits, 658. Please press star 6 to unmute.
Thank you, Chairman. My name is Deanna Leivas, D-E-A-N-N-A-L-E-I-V-A-S. I am the Secretary Treasurer of UFCW Local 711. On behalf of the 6,800 members of United Food and Commercial Workers Local 711, I'm speaking in support of SB 329. SB 329 will allow the state, policymakers, patients, payers, and other stakeholders to understand consolidation in our healthcare markets and its impact on prices, affordability, quality, and access. It will provide vital information to guide decisions that protect competition and patient choice. SB 329 will also prohibit anti-competitive contracting practices that hospitals and healthcare providers with market dominance can demand because payers have to have them in their networks. This will prevent dominant market participants from exercising their market power to drive up prices and thwart competition based on price and quality. Anti-competitive contracting practices like all or nothing, anti-steering, and anti-tiering prevent health plans from directing or incentivizing patients towards lower cost, higher quality care. These provisions also prevent other hospitals from benefiting if they offer better deals or higher quality. They also stop patients and health plans from shopping for and getting the best deal. SB 329 will prohibit anti-tiering and anti-steering clauses, which require health plans to place all of a health system's hospitals in the most favorable tier with the lowest cost sharing regardless of the rates they are charging or their quality. Thank you, and I urge you to pass SB 329.
Thank you. If we can go to our next caller in support.
Caller with the last 3 digits, 598. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Justin Larson. That is Justonlarsen. I am a 4-load Starbucks barista from the airport and a Culinary Union member. I am testifying today in support of Senate Bill 329. I've had asthma since I was a child. I carry an inhaler everywhere I go, just in case I have an asthma attack. I want to be informed and an empowered patient, so I need to have information to be able to better advocate for myself. I trust my Culinary Health Fund to help make sure I'm going to the best quality of care for the lowest price. I wish that my Culinary Health Fund advocate could give me advice on which place is best for me to go. A place that is safe, a medical professional that is a good doctor, and a clinic that is the lowest copay for me. But right now, due to anti-steering and anti-tiering language in hospital contracts, my Culinary Health Fund is not able to give me complete information that I need and deserve That is not right. Removing anti-competitive clauses from hospital contracts will allow my culinary health fund to better give me the complete information so I can get my health needs met better. So please support Senate Bill 329. Thank you.
Thank you. And if we can go to our next caller in support.
If you've recently joined the call or have not been called on yet in support of Senate Bill 329, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 721, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Todd Inglesby, TODDINGALSBEE. Good afternoon, Madam Chair and members of the committee. My name is Todd Inglesby. I'm the president of the Professional Firefighters in Nevada. We are here in support of SB 329. Managing our health care and its costs is a full-time job for us. We are constantly putting our lives and health on the line. From work-related physical injuries to heart and lung disease due to the cancer-causing carcinogens we are exposed to daily, it is vitally important that this piece of legislation pass. Without this, we have situations where we are unable to communicate to our members about where they can get the best care due to anti-tiering and anti-steering language that we are forced into with our hospital contracts. Our self-funded health trusts need to be able to educate our members, especially about where they can get the highest quality and lowest cost care. And there are many times where we are prohibited from doing that, especially in the field that is so ripe with injuries, disease, and unfortunately premature death. It is wrong that we are restricted from giving our members the basic information. This bill brings transparency about what is going on in the healthcare market in Nevada and allows us to educate our members about the best options out there for them. We ask your support for SB 329 and help our members so they're able to take care of themselves so we can take care of all our residents and guests to Nevada. Thank you.
Chair, there are no more callers in support at this time.
Thank you. At this time, we will begin testimony in opposition to Senate Bill 329. I will start here in the room. If you are here to testify in opposition, I'd ask that you come up to the table and begin your testimony.
I'm George Ross, testifying on behalf of Sunrise, Mountain View, and Southern Hills Hospitals. I'd like to thank Chair Nguyen for the privilege of appearing here today. Do I have just 2 minutes, or can I use about 3?
You know what? Go ahead with your testimony. We may have some additional questions for you as well from committee members.
Okay. First, I want to express our profound appreciation to the sponsor of the bill, Senator Lang. She met with us with an open mind and gave us a great deal of time to go over this bill, and we really appreciated that. The most critical piece of this bill is the antitrust section 20.9.1. HCA does not do A, they do not do B, they do not do E. So what we're really going to focus on is C and D. With regard to C, we believe that the provider should be explicitly permitted to offer incentives in the contract bargaining process to include those of its owned entities in the contract or in the same tier. The proponent seemed to imply that they thought this would be the case. But there are lawyers out there who I've talked to who have read this and believe that this may prohibit that from happening. We would like to have explicit language allowing the provider to offer such incentives. This would enable a higher volume of patients and thus enable a more discounted rate. It would also permit coordination of care. HCA has consciously put together a system which enables the providers to get the patient to the right place for the needed treatment in a timely manner, thus seamlessly to the patient. So that we would like to be able to explicitly know that that's permitted to do. And why that's important is that at the end of this bill, it says a violation of this section is a felony. And this language is pretty vague. We've already had discussions as to what it means. It's very important that normal bargaining process not get you into a situation where you can be accused by an aggressive attorney or an aggressive opponent of committing a felony. With regard to D, similarly, the provider should be able to incentivize the payer to contract with affiliated groups. And what we're thinking of here is those groups that provide your radiology treatment, your anesthesiology treatment, your hospitalists. Having these together is essential to provide the continuity and coordination of care, as well as preventing the difficult situation that can happen when a patient thinks he's going or she's going to an inpatient, to an in-network hospital, and then wakes up after surgery to find out that the anesthesiologist or the radiologist or the next morning the hospitalist is in a different network. And all of a sudden they're paying out-of-network charges. Plus, when you don't have that connections, you have much less coordination, much less cooperation. So we'd love to see that section cut out altogether, but if not, it should be changed to explicitly permit the provider to incentivize the payer in the bargaining process to contract with affiliated groups as a necessary for proper continuity, coordination, and integration of care. Without that, this puts the patient in a very difficult situation. And I would point out that my understanding is that the Sutter Agreement, which was referred to, actually allows hospitals to ask for the contracts with doctors providing services in that area or in that hospital for the reason of continuity of care. It's not a law, it's only a settlement, but they apparently made that provision. So essentially, failure to fix C and D, as we're asking, leaves the patients in a very difficult situation. They would be facing a fragmented, disorganized, confusing medical environment in terms of both healthcare and figuring out their billing. Now, I know that there are certain payers, and we've heard from one of them here today extensively, who probably take their patients almost by the hand and guide them around. And so, but the vast, vast majority of Nevadans are not in that situation. And they are left to do this on their own. And I can tell you, going through this now that I'm not quite as young as I used to be, and my wife isn't either, we're doing a lot of healthcare. And it is quite a confusing situation. And having everybody at least in the same network certainly would make life exceptionally easier. Finally, antitrust violations should not constitute a felony. Antitrust cases are typically civil cases. The language of C and D is ambiguous and open to very varied interpretations. To make trying to achieve a situation where the doctor groups serving a hospital are in a payer's network a felony is a recipe for much worse and expensive care, as well as a very anxious and confusing world for the patient. And since the beginning statements in the early part of this testimony for the bill talked a lot about healthcare costs, and this is a way to bring down healthcare costs. So I think I have the right then to say that the single most important thing this legislature and the advocates of this bill could do to bring down their healthcare costs is to join together with all of us and convince the legislature to increase Medicaid reimbursements to providers. The single reason why those costs are so high is because we have to shift such a large amount of costs onto the commercial and trust fund payers. Very simple. We talked about it. We saw the chart from the lady from Hastings about how much healthcare costs have gone up. Well, since 2001, hospitals have got one raise in Medicaid of 2.5%, which was taken away from us last summer again. That's all we've gotten. If you wonder why costs are going up, that is a very, very large reason. Thank you.
And Mr. Ross, if I can have you sit there for a second
Sure.
to see if there's anyone that has any follow-up questions. Go ahead, Assemblywoman Benitez Thompson.
I appreciate that. And so I guess going back to the same question that I had about in the 20.9 on the shall nots and the A through E, and it looks like we've got A, B, and E off the table, and we're focusing on C and D. So I guess could you just talk a little bit more about the practices that are allowed now that will become the shall nots, and then what it will allow from your perspective?
Well, I can't speak for any other company on that, and I'm not the negotiator on ours, but I can tell you that we do not require them all to be in the same tier. We do not require them all to be contract with all of our entities, but we would like to be able to incentivize them to do so if we chose to, and if we could give them an incentive good enough for them to do it, we'd love that. But
Perfect.
and hopefully they would find the lower price we could give them for that volume to be attractive as part of the bargaining process. We just want to make sure that the normal bargaining process, because of the way this bill is worded, is not suddenly becoming a crime.
I appreciate that. I guess, once again, going to incentives to make sure we have a clear for the record, I guess in the way that we've been talking about it, it seems to be to mean financial incentives. Is that right?
That's, yes, obviously.
So, like on the D with the contracting with the affiliate. So obviously, if a hospital wants to say, okay, here's the hospital network we've built out. So not the insurers network, but the hospital networks we've built out. So we've got the hospital, and then we've got the clinics, and we've got an urgent care. We've got specialties, right? So so the idea would be there just to incentivize people to stay in the hospital network, and that would be contracted and negotiated, the incentive to stay in versus, I guess the way it's being talked about right now in the status quo, you're all in for the hospital's network, or you're not. It's kind of all one kit and caboodle.
We don't mandate that, but we like to incentivize it, but we don't mandate it. We don't. That I know for sure. But in terms of D, that has to do with the way we read that when it said affiliated entities. It's not necessarily the ones we own, but it's the ones we believe that means, in this case, is basically we're talking about, where our lawyers read it and our negotiators, is talking about the doctors group that we made a contract with to do the radiology, the doctors group we made a contract with to do the ER, and so on. All the places where you get a doctors group to do it. I didn't mention ER because that situation was pretty well taken care of last session. So I've been focusing on the others. But it's a real mess when you go and all of a sudden you got to pay an out-of-network. Suddenly you're sitting there with an out-of-network doctor when you're in an in-network hospital. And if we can, from a patient point of view, those are the kind of things that you say, what does this bill mean? Why do I have this? Why do I have that? And, it drives you crazy. And this will make life a lot simpler, a lot more organized, but even more importantly, it will help coordinating care. Because when you can when your hospitals are working with these groups where they have contracts, they can interact and coordinate. The best example I can give you of some of this is when I had an operation at Mountain View on my elbow and had my stitches out. The next morning, I guess I moved around too much in the bed and got a lot of blood on my pillow in my bed. So I got in the car and ran down the freeway to Southern Hills in the ER. It took me about 10 to 15 seconds to get in there because all my info was right there. Same computer system. Boom. They had everything they needed. Very coordinated. They could see everything that happened to me right there. And if you start having all these discrete groups, I respect what the proponents are trying to do here. You can see this. If they have a point. I mean, they have a noble objective. But I think that we want to make sure that our ability to provide the best possible care that we can in a coordinated manner to the patients and to give them as good an experience as possible is not inadvertently or advertently eliminated by the way this bill is worded.
And I guess I should clarify, when I was saying like the hospital and kind of their network, and I was referencing the buildings, we know that, well, I guess for most people who work in hospitals, that no one's like, very few people are like hospital employees. They've got the brick and the mortar, and then you hire the groups to come in and kind of the physician groups to come in, most likely the physician groups. So you might, the admin, you have And those tend to be like the payroll, the HR, and maybe some other ones tend to be direct employees, but I don't know, maybe 10% of the people you see in a hospital are actually hospital employees and the rest are contract groups. So
The nurses are all employees.
the nurses, yeah. And so when you get to, when I'm talking about those kind of specialty clinics or the urgent cares, it's the groups that are staffing those. So on E, it talks about shall not do exclusive contracting. So then those provider groups will just have to go, will be contracting with multiple
They're right.
insurance, multiple entities as well, which I think that they can do now, right? Because we
have no
kind of have
problem
some
with
case
that.
law
That's
on
correct.
that.
That's correct. We have no problem with doing that. We don't stop them from doing that. We have no problem with that piece of the bill. If you got a group that wants to contract with 2 or 3 different hospital groups, fine.
I think we also have a question from Assemblywoman Summers Armstrong. We can go to her next.
Thank you so much, sir, for sticking in there with us to answer all these questions. This is really complicated.
Yes, it is.
And I think that our intent is to do the right thing for our constituents. My question is, this bill, if I'm not mistaken, when I listened to the earlier testimony, does not allow for there to be fines and fees if people don't comply. So if there's no vehicle for fines and fees, and the only vehicle that's allowed here is a felony or some type of what else can be done? Because I think we've seen enough corporate misbehavior that even often when people are fined, they continue poor behavior because they can afford to pay. And so, I mean, it may seem egregious, but maybe if you've got a suggestion how we can get people to comply, I'd like to hear it.
You could at least make it a misdemeanor, not a felony. But ideally, you could put fines and you could put penalties in that are meaningful. But even then, we would think, if you just allow normal bargaining, because the proponents referenced several times, that's part of bargaining the contract. If you could just put in here that we're allowed to incentivize things, those items that I talked about, we wouldn't have any worries and we wouldn't be worrying about getting a felony because we wouldn't be breaking the law. We don't do A, we don't do B, we don't do E. So, and we just want to make sure that we can continue to provide coordinated, high-quality care that's good for the patient and puts the patient in a good place without committing a felony.
And if I could just clarify, Mr. Ross, doesn't 598 already have those violations already go to district court? Isn't that existing statute?
I'm not an attorney, and so I could not.
If I can go to Ms. O'Krent, I believe that is already existing in the statute, so this isn't a new provision for the felony. Ms. O'Krent, can you clarify that, or do you need some additional time?
Charlie O'Krent for the record, that's correct.
Yeah, I just wanted to make sure that record was clear, that is existing language that's already existing in chapter 598.
If I could comment that I have done a lot of health lobbying up here for about 2 decades, and every time you change a healthcare law, it shows up in about one little blue line and about 7 or 8 very long paragraphs because there are all these different kinds. I see no reason why this can't be. I'm not the lawyer, but someone ought to look. Maybe we could put a different section. Get rid of the felony. If that's what it requires, make a new section.
Okay, Mr. Ross, at this time I'm going to go to, are there any other individuals in the room to testify in opposition to Senate Bill 329? Oh, you do. Well, actually, one second. I'm going to go to Miss Assemblywoman Krasner.
Thank you, Chairwoman. Thank you, Mr. Ross, for being here. So, this is a complicated bill, but I do know that when people get sick or their loved one gets sick, they want the state-of-the-art hospital. They want the best doctors. But here in Nevada, we have one of the lowest Medicaid reimbursement rates in the United States. And in the special session, we reduced it an additional 6% to the Medicaid reimbursement rate. So those factors taken and coupled in with this bill, how is it going to affect our state and healthcare for people in our state? Thank you.
Well, I don't think it will help. As I pointed out, if it passes as it's written, I think it'll have a negative impact on how people see healthcare and how people experience healthcare. And for the reasons I stated, I have no question about that. I think the best thing we can do to improve healthcare in this state is to increase the because you need to pay doctors enough to take Medicaid patients. You know, we're very low on medical, but when you go down, you drive through Henderson, you drive through parts of Summerlin, you don't see any shortage of doctors. Where you see the shortage of doctors is in East Las Vegas, North Las Vegas, Northeast Las Vegas. And where do the majority of the folks who are on Medicaid live? In those same places I just said. You need to pay the doctors enough that they will take and see Medicaid patients. And similarly, if you paid the hospitals somewhat fair rate, comparable to other states, we have I know it was said earlier, but we do have at least 5 entities who own hospitals in Las Vegas. You know, it's fairly competitive when you do those contracts. You know, it's one reason why somebody apparently tries some of these other things to get an edge. It's quite competitive. So it won't take long if you start raising the Medicaid reimbursement rates when the cost shifting gets less and the contracts to the providers, rather to the payers, go down. And you know, we don't like having to do that. But if you don't push those rates up, you know, the hospital doesn't survive. Yes, we make a lot of money nationally.
Mr. Ross, can I get you to direct this towards the contents of this bill and how it might affect? I feel we're going down a rabbit hole about Medicaid reimbursements.
I apologize. I was trying to answer the question.
That's fine. Thank you.
I apologize.
No, that's okay. I just know that we have other people that want to testify here as well. So I'm going to start going to them. So if we could, Broadcast Services, if we could go to the line to receive testimony in opposition to Senate Bill 329. Again, I would remind callers to please state their name and limit your testimony to 2 minutes. If you don't mind, if you would like to stay on the line, we may have members that have additional questions for you, but I would ask you to limit your testimony to 2 minutes. Thank you. Let's begin.
To testify in opposition to Senate Bill 329, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 020, please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last 3 digits, 020, please press star 6 to unmute.
Thank you, Madam Chair and members of the committee. For the record, my name is Jim Wadhams. I'm speaking on behalf of the Nevada Hospital Association. And first of all, I'd like to thank Senator Lang for the time that she spent, actually many, many hours, talking openly, and the sponsors of the bill, including Bobette Bond and Stacy Sasso. That has been a very open and robust discussion. And the bill with the Amendment 447 is actually much improved. We do still have some concerns, and part of the reason has been addressed in these questions. There is not only a felony potential, but there is a private right of action, treble damages, and attorney's fees. So this element of the Section 20.9 is very serious, and it has to be precise. Many of the members' questions have drawn attention to the ambiguity, for example, in the phrase in what we've just been talking about, C and D, on business affiliate. Does that mean the affiliation of the in-house basic hospital services, such as lab and radiology and anesthesiology, or is that a reference to external but affiliated facilities? That needs to be clarified for all the reasons of the treble damages and the felony. I think the other element is making sure that the language, and if the committee will look at page 21 of the amendment anyway, it's section 20.9 subsection 1, I think there's a concern that there may be an ambiguity in the way that language is written, that a restriction on changing the incentives after the contract is entered into may be barred as well. And I don't think that's the sponsors and clearly not the senator's intent. And I don't think from what we've heard from the proponents that's their intent. And I think the language needs to be clarified in that regard. Finally, I think it would be worthwhile at least to have committee counsel take a look at the reference to a third party when we are actually talking about a hospital or a provider, physician provider, entering into a contract with a payer. They are counterparties to the same contract. One is not an unrelated third party. So the technical elements of this and eliminating antitrust provisions by themselves are not the problem that we have with this bill. It is making sure that it is clear and doesn't impede the open contracting otherwise that occurs in this highly competitive environment. So once again, I appreciate the opportunity to testify. Thank you, Madam Chair.
Thank you, Mr. Wadhams. Can we go to our next caller in opposition?
Caller with the last three digits, 122, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Nguyen, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I'm System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. St. Rose is also in opposition to SB 329 for many of the reasons already cited by my colleagues. Anti-competitive practices are not an issue in the state, and if there are any health systems doing this, the AG's office can deal with bad actors. St. Rose also does not mandate that payers contract with our entire network. The contracting restrictions piece of the bill in Section 20.9 is severely problematic and will make navigating healthcare coverage even more difficult for patients, while also creating access to care and quality issues by interrupting the continuum of care. This could also be harmful to health equity. There is nothing in this bill that would prevent payers from making their members go to the cheapest place of care and not giving them a choice. How is this confusion and frustration better for the patient? This benefits the payer's bottom line, not the patient. That being said, St. Rose is willing to work with the sponsor on this bill in conjunction with the Nevada Hospital Association and hope we can come to a resolution. Thank you.
Caller with the last three digits, 900, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair. Dan Musgrove on behalf of the Valley Health System of Hospitals. That's DAN, capital MUSGROVE. I won't be repetitive. Mr. Ross, Mr. Wadhams, and Ms. Ryan were excellent in their comments. The Valley Health System has a number of hospitals in Southern Nevada, and we're beginning to start a second hospital in Reno. We have one currently in Sparks. And as was discussed, there is something to be said for continuity of care. And I think Mr. Ross captured it very correctly. But, there is an ability for us to go to exactly what Assemblywoman Krasner said, in that when someone shows up at our door in an emergency situation, they want the best of care. And we save systems money, insurance systems money, by not replicating, NICUs throughout our whole system or other services where we can easily transfer them within our system to make sure that they get the absolute best of care. And our concerns, as been said, has been Section 20.9, and we ask that you sincerely consider our suggested amendment. Thank you very much for the opportunity to testify.
Caller with the last three digits, 139. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair Nguyen and committee members and Senator Lang for having an open door to working with us on SB 329. Misty Grimmer, Grimmer, with the Ferraro Group representing North Vista Hospital. North Vista is the only hospital in North Las Vegas and in the oldest part of North Las Vegas. We echo the statements of the other hospitals you've heard from today, especially Mr. Ross's comments about asking the legislature to stop the cost shifting that happens from Medicaid to commercial payers by increasing Medicaid rates. We are a small hospital compared to others in Las Vegas and have just one location in Las Vegas. Therefore, the ability to have as much flexibility with our contracting as possible is very important. Therefore, we too are in opposition to SB 329 as currently drafted. Thank you very much.
Caller with the last 3 digits, 503. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, Chair and committee members. My name is Chris Bosse. That's B-O-S-S-E for the record, representing Renowned Health in Reno, Nevada. We appreciate Senator Lang and the representatives of the Culinary Health Fund for initially working with the industry on the bill and working to determine if there were unintended consequences that could be corrected in the bill language. We do, however, oppose SB 329 as amended, as the majority of our concerns have not yet been addressed. Our primary concerns include the following. First, we believe payers and providers should be allowed to negotiate and mutually agree on contract terms. SB 329 prohibits parties from negotiating certain terms that may result in providers not being able to offer their best volume discounts if they can't confirm the payer's members won't be directed away from them. In addition, as an integrated delivery system, Renowned Health provides value to its patients and those employer groups and payers that we contract with by being able to provide high quality care in the most cost-effective setting, including this past year during the COVID pandemic, in the patient where we provided care in the patient's home when it was appropriate. Excluding or steering patients around the components of our delivery system has the potential of diminishing our ability to meet the patient's needs. By connecting the components of the healthcare delivery system, we're able to coordinate care, hold the components of the delivery system accountable to outcomes, and improve communication between levels of care and the patient. SB 329, undermines the components that nationally CMS has encouraged healthcare delivery systems to build through establishing accountable care organizations, ACOs, which have demonstrated the ability to improve quality and provide care most cost effectively. As stated previously, we oppose the bill and hope to be given the opportunity to work with Senator Lang and the Culinary Health Fund to address these concerns. Thank you.
Chair, there are no more callers in opposition at this time.
Thank you. At this time, I will go to neutral testimony on Senate Bill 329. Is there anyone in the room to provide neutral testimony? Seeing no one running to the table, I'm going to go to our Zoom. Is there anyone on the Zoom to testify in neutral on Senate Bill 329? Looking, I don't see anyone popping their camera on right now, so broadcast services, if we can go to the line.
Testify in neutral to Senate Bill 329. Please press star 9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you. And if I can call our bill sponsor back up to the table, Senator Lang, for any closing remarks, if any. And
thank you, Chair. I won't be long. I don't want to stand in between everyone's Cinco de Mayo celebration this evening. But we've heard a lot today, and you're all right. This is a very complex bill. And we wouldn't bring this bill to you if there hadn't been reasons that needed it. And so we continue to work with the hospitals, who are the people that seem to have the most problems with the bill. We are going to work to amend the bill to include Optum and groups like that to make sure they have the same reporting requirements as other groups. Mr. Ross and I talked about that earlier in the week. We just wanted to make sure that we could get the bill to you in a timely manner. And you heard today that from legal that the felony is not something we wanted to add in. It's something that's already in statute that is applicable to this language as well. And so that's why that's there. We also know that the Attorney General deals with monopolies, and he He can go after monopolies. We want to be able to give the Attorney General some teeth into antitrust stuff that's happening or that could happen in our healthcare system in Nevada. And that's why legislative language and statute is so important in this bill. So we are open to any questions you might have. If you are thinking about it at night and you come up with something, feel free to send me an email. I'm happy to connect you with any of the presenters. And I just thank you for your time. It was a long hearing.
Thank you, Senator Lang, and I thank you to the committee. You guys have been very patient. I know that when I said we weren't going to be having committee last Friday to allow people some time to grieve and mourn and attend the services, that we would have a long week. So I appreciate everyone's patience here today in being so attentive to the bills that were presented before us. And with that, I will close the hearing on Senate Bill 329. And we will move to public comment, broadcast services. Do we have anyone in the room to provide public comment? Seeing no one, I will go ahead to go to the lines. Is there anyone on the line in public comment?
To participate in public comment, please press star 9 to take your place in the queue. Chair, there are no callers wishing to participate in public comment at this time.
Thank you. And that I will close public comment and I will open up to see if there's any comments from members. Seeing none, this time I will adjourn today's meeting and see you all on Friday. Have a good day.